stem, and in the end, you also know the anatomy. Okay, posteriorly, we can find a radial head. Radial head is the disc-like structure, and the cartilage covered around the radial end about 280 degrees. And posteriorly, we can find the most prominent structure here. This is the olecranon process, which is the tricep tendon insertion site. And distally, we can find the segmental crest. This is also a significant structure. And let's move on to the muscles attachment. And knowing the muscular attachment happens not only with sonographic identification, but also with targeting treatment. Laterally, we have the common extensor tendon, extensor carpi radialis brevis, and above is the extensor carpi radialis longus, originating from the supracondylar ridge. And immediately we can find the plantaris and the common flex tendon. And the brachialis insert and the ulnar tuberosity here. Brachialis tendon and the biceps tendon is already insert to the radial tuberosity. Okay. The posterior can find the tricep tendon, and laterally we can find the coneus and the supinator. Okay. And this is the anterior transverse ultrasound view. We put the poke on the anti-cubital fossa here, transverse. First, we can use the bony landmark to identify our poke. First, we can see the wavy contour here. This is autochondral structure. And laterally is our capitulum. This is a convex structure. And medially is a trochlear structure. It's a concave. So we can use the bony contour to identify these two joints. And yeah, it's a capitulum and trochlear. And trochlear has two facets, a lateral facet and a medial facet, and like the concave, like a valley here. And above this bony structure is three important muscles. Like the lateral side is brachioradialis, line, central is brachialis, and medially is plantaris. And this one is the bicep tendon. And then we can find the nerve structure just between the muscles. Between the brachioradialis muscle and brachialis muscle is the radial nerve, and between the plantaris and brachialis is the medial nerve. And we can also identify the small nerve here, just near the vessel. This vessel is the cephalic vein. This nerve is the lateral anti-brachial trapezius nerve. It's very small, but also important, because sometimes we can find that some enchantment here. Okay, this is the vessel, cephalic vessel, and brachial artery. Okay. And then we rotate the poke 90 degrees into a longitudinal plane. Here. We can find the capitulum radial joint. This is the capitulum. From the medial side, we first to see the trochlear joint. This is the coronary process. This is coronary fossa. And above this structure is the brachialis muscle. Okay. And we can partially see the part of the plantaris. Then move our poke laterally. We can see the capitulum radial joint here. The radial head, and the capitulum, and radial fossa. And this fossa is receive the radial head when the elbow is flexed. Okay, the radial neck over here. And this is brachioradialis, can see the part of the supinator over here. Okay. And then let's move on. In this view, let me trace the brachialis tendon. You can like this orientation, just like you to scan the trochlear ulnar joint. But if you want to trace the brachialis tendon insertion, you need to slightly orient your probe medially, because that you can find the whole tendon of the brachialis. This is the brachialis tendon, and finally to insert to the ulnar tuberosity. We know that the brachialis muscle have two heads, the superficial head and the deep head. So you use this method, you can find the tendon in the center of the brachialis muscle, and above is the superficial head of brachialis, and in the deep is the deep head of brachialis. And we can find the plantar teres above the brachialis. This is the humeral head of the plantar teres. And ulnar tuberosity. Okay. And then we want to evaluate the distal bicep tendon insertion. And we commonly use this 4-standard ultrasound method to find the distal bicep tendon anteriorly, laterally, medially, and posteriorly. And each offers a spatial window to evaluate the bicep tendon insertion. Okay. This is the anterior approach. Let the patient to strike his elbow, and let's put the probe longitudinal in the anti-acute fossa. And then we can find the bicep tendon insertion. But one of the challenges of this view is anisotropy, because the bicep tendon is curved deeply to insert to the radial tuberosity. So if you just put a probe here, you may find that there is some hypoechoic defect over here. It is not a pathology, but also but it is anisotropy. So you need to apply the probe gently, give a gently pressure over here to let the bicep tendon flat and reduce the anisotropy. And this is one of the important techniques to do the anterior approach of the bicep tendon insertion. Okay, now we know that the bicep tendon has two heads, long head and the short head. And let me check the anatomic diagram here. We can find that after the muscular tendinous junction, the bicep tendon separate to head. It goes separately, and it also insert separately. The number one is the long head. The number two is the short head. The most important is that you know the long head is insert more proximally, and the short head is insert more distally. Okay, and on the ultrasound, how could we to differentiate the short head and the long head? We have the two methods to differentiate these two heads. First, we can use the anisotropy. As previously I said, anisotropy is a challenge, but also it may have it's a helpful tool for scanning. In this situation, we can use anisotropy to identify these two heads. You can see in the left side is the more big one. The big one is this is the long head. The small one and more flattened is the short head. And if not very clear, you can rotate or tilt it or rock your probe slightly, and then we can find the two hollow here. in using this anatomical method, we can more easily to identify the long head and short head. Or alternately, you can use the anatomical position to identify these two heads. We scan from the humerus proximal to distally. We can find that the short head and the long head, their position is changed. From the proximal, the short head is lying medially to the long head, but when you scan distally, you may find that the short head cross above the long head. So you can also use this method to identify the two heads of the bicep tendon. Okay, and let's go to the other method. The laterally, you ask a patient to left elbow press 90 degree and connection, and use both parallel to the humerus, and we can find the bicep tendon here to insert to the radial tuberosity. And the middle approach, again, ask patient to flex the elbow 90 degree, and we scan medially to the bicep tendon, parallel to the humerus, and then we can find the bicep tendon here. Use the planetaris window. And from the posterior approach, and in this approach, we let the poke transversely to see the bicep tendon over here. Let the patient to flex elbow 90 degree, and in this position, you can do the dynamic scan. You ask patient to connection their forearm. We can see the bicep tendon over here. And this is from the lateral approach. The bicep tendon is identified by the red dot. You can see here. And from the lateral approach, we use the brachioradialis muscle as a window to see the bicep tendon. And for the middle approach, I would like to introduce a method called the radial arc technique, because this method allows us to more clearly to trace the bicep tendon. You ask patient to flex the elbow 30 degrees and pull the cushion, and the forearm position is in the neutral position between the pronation and supination. And firstly, you identify the medial epicondyle, and then you angle your poke laterally and deeply. Then you will find the radial arc here. What is the radial arc? Radial like the valley. The hill is the radial head, two here. Radial head and radial tuberosity. And the valley is the radial neck. You find this structure. And then you fix the distal poke on the radial tuberosity and rotate your poke to follow the orientation of the bicep tendon. Then you can find the bicep tendon. And in this method, you also can identify the short head and long head. The long head is a little bit convexity here, and the short head is more straight, more flat. Let me show you the video. We can find the medial epicondyle and the ulnar trochlear joint here, and move the poke to find the radial arc here. The radial head, radial neck, and radial tuberosity, and the fixed poke distally and rotate. This is the brachial artery here, and this is the bicep tendon. Now we can slightly to find the short head and long head. Okay, and this is the Lester's fibrosis. Previously, we trace the bicep tendon insertion, and immediately we can find the bicep aponeurosis. It's so-called lesser fibrosis. This lesser fibrosis covers superficial to the brachial artery and to wrap around the medial muscle, the plantaris and the flaccid muscle. And you can use the vein and artery as a landmark to identify this structure. Because this structure identified by the yellow dot from the lateral to the medial, it will superficial to the brachial artery, but below the brachial vein. So you can use the artery and vein to identify the lateral fibrosis. This is the hyperechoic vein over here. Okay, and that's from the lateral elbow. Yeah, we can find the lateral econdyle, radial head, and the common tendon, origin, and the radial collateral ligament. And this is a longitudinal, and then we put the pole 90 degrees to find the transverse view. We can find the supinator here from the radial head, and the medial side is the extensor carpi ulnaris, and this is the tendon pulse, the extensor determinus, extensor pectoris, and extensor carpi radialis brevis. This is an important structure here, like a big structure. This is the extensor carpi radialis brevis tendon. So if you want to scan a lateral elbow transversely, you can identify this structure first, because this is that you know this structure, this muscle is an extensor carpi radialis brevis. Okay. And when scanned along the lateral elbow in the transverse view, from distally to proximally, and we follow the common extensor back to the origin. We can find that from the radial hand over here, C-like structure, and radial hand, and the extensor tendon converge to a conjoint tendon, common extensor tendon, and to the lateral epicondyle. And as we reach the lateral epicondyle, we can find this all extensor tendon converge in a well-defined oval-shaped structure at its origin and the bony cortex. Okay, and let's move on to the ligamental structure. The lateral side is a lateral ulnar collateral ligament, radial collateral ligament, and anterior ligament. The medial side is the ulnar collateral ligament, anterior, transverse, and posterior part. And this is the lateral ulnar collateral ligament. I think it's the most important ligament of the elbow. We can see that from the lateral econdyle and cross to the radial head, and finally insert to the supinated crest of the ulnar bone. And this is a variant of the lateral ulnar collateral ligament. Okay. And we can use the cobra view for lateral ulnar collateral ligament and anterior ligament, like this. Ask the patient to do this, because in this position, the lateral ulnar collateral ligament is tight, so you can scan it more clearly, like this one. Okay. And the posterior lateral ligament is a newly described structure and considered a specialized thickening of the posterior joint capsule. You can see here, just laterally and inferiorly to the lateral ulnar collateral ligament. And also very important to provide the lateral elbow stability. Okay, let me check. This green line is the anterior ligament, and purple one is the lateral collateral ligament. And if you want to trace the lateral ulnar Kyoto ligament, you can use the bony structure to identify. And when I scan the lateral ulnar collateral ligament, you need to find the 3 points: humerus, radial head, radius, and ulnar, because the lateral ulnar collateral is a very oblique structure to cross 3 bones, and this is the posterior lateral ligament. Okay, and the medial side, find the common flexor tendon, and this one is the anterior band of the ulnar collateral ligament, and the posterior view. And we place a probe longitudinal over the olecranon and distal humerus. We can find the tricep tendon insertion to the olecranon, and this is the coronal fossa, and above the fossa is the flathead. Okay, and let's go to the nerve system: medial nerve, ulnar nerve, and radial nerve. And there are 4 possible entrapment sites of the medial nerve. The first one is the distal humerus by the ligamental structures. And structure is a very rare case. They only present in 3% population. And try to not confuse with the arcade of the structures. That's in the 2 different structures. The arcade of the structure is in the medial nerve, and one of the entrapment sites of the ulnar nerve. Arcade of the structure is in the ulnar nerve, but the ligament of the structure is in the medial nerve. But this structure is very rare, and lateral fibrosis, as previously I said, and the pronator tunnel and the sublineus bridge. The most important, the most common entrapment of medial nerve is the pronator tunnel. Okay, we can see the pronator here in transverse view and longitudinal view. The pronator tunnel is between the radial head of the pronator teres and the ulnar head. This is the ulnar head of the pronator teres. And the sublineus bridge. Sublineus bridge is the fibrous arc of the flexor digitorum superficialis. After passing the pronator tunnel, the medial nerve then entering the sublineus bridge. This may be another entrapment site of the medial nerve. Okay, let's move on to the ulnar nerve. There are 3 possible entrapment sites: arcade of structures. This is intermuscular septum of the mid humerus, and the cubital tunnel, ligamental ossibone, and then the flexor carpi ulnaris muscle. Okay, the most entrapment site is cubital tunnel, entrapped by the ossibone ligament, and this is after passing the cubital tunnel, the flexor carpi ulnaris. Okay, finally is the radial nerve. There are 5 entrapment sites. The level of the radial end by fibrous band between the brachioradialis and joint capsule, and visual Henry. This is an anastomosing branch of the radial recurrent artery, and the canal stage of the ECRP, and the arcade of force, and the eclipse of the supinator tunnel here. Okay, this is the brachioradialis and the joint capsule entrapment site, and this is supinator tunnel here. The entry point is the arcade of force, and the exit point. This 2 points also the entrapment site, and this is the visual Henry. You can find in this level, you can find artery cross over here. This is a recurrent radial artery from the cephalic artery. This is also an entrapment site. Okay. Finally, we talk about briefly about the ultrasound guide injection. Let me focus on the protherapy, because the protherapy is aimed to restore the structural integrity. So I use the lateral epicondylopas as example. You not only to treat the tendon, but you need to rebuild the whole biotensivity. You need to treat the lateral ligament complex, and you need to treat the annual ligament and the lateral collateral ligament. The treatment goes beyond the tendon itself. Okay. Use this position, and this is the treatment view of the common extended tendon. The entry point is here. You just need one entry point and can treat a very target. The numbness here, and you treat the annual ligament, the radial collateral ligament, and common extended tendon, extension carpi brevis here, and you also can hydrodissect this layer. This layer is the posterior antebrachial cutaneous nerve. And also, some patient has the lateral epicondylopathy, has the nerve inflammation, so you can hydrodissect the layer over here. And then you turn the poke 90 degrees to see the outline. Because the tendinopathy of the tendon here, not only a linear, but also you need to cover all the tendon here side. So you need to turn the poke 90 degrees to use the out plane to target all this side. And then you pivot your poke to find the lateral ulnar collateral ligament, and this ligament also need to be treated. Okay. In summary, understanding the detailed sonograph of the elbow is essential, not for fracture diagnosis, but also for the self and effect. The brachioradialis, brachialis, and prolongataris. And between the muscle is the nerve, the median nerve and the radial nerve. Okay. And then poke. And turn the poke 90 degrees. Yeah, we can find this is the medium. We can find the trochlear ulnar joint. And then we can in this view to trace the brachialis tendon insertion. So we turn the poke distal end. Yeah. You can see the brachialis tendon insert to the radial velocity. Okay. And lateral is the posterior radial joint here. Okay. And left trace the distal bicep tendon insertion. The bicep tendon insertion is over here. Yeah. Yeah. In this patient, we can easily to identify the long hand and the short hand. We can use the social V method to identify. The lateral side is the most big one is the long head, the middle side is the short head. And turn the poke 90 degrees. You need to apply some pressure over here because the bicep tendon is curved deeply, so you need to flat the bicep tendon.
Dr. Yu, I have a question for you.
Okay.
So what is the most important area in the distal biceps tendon? So mid-portion tendinopathy or insertional tendinopathy as the radius? Which?
I think it's the insertion.
Insertion. So we should you mean we should pay attention to the insertion to the radius, right?
Yes. Okay. Here. And the forearm is in neutral position. Okay. But first, we can find the medial ground line and the trochlear ulnar joint. And in this view, we can also see the anterior plane of the ulnar collateral ligament. And then we move the top horizontally. And then go up.
Oh.
And we can see increase the depth.
Now we can see the radius here, right?
Yeah, radio is here, but this traverse is not very prominent. In this view, we can fix the distal end of the pole and rotate the partial one. Here.
This guy?
Yeah, this one. Here.
Oh. Yes, we can see a very clear tendon inside the radius. Wow.
And you can adjust the foot to find maybe we can find the two heads of the bicycle. The superficial tendon layer is a little bit convex, it's a long head, and it's in somewhat distally and more straight is a short head. Obviously, you can find the two tendons here.
So what tendon here is muscle?
Tendon.
What muscle is?
Long head bicep. No, the bicep tendon.
The bicep tendon. Yeah.
This is the bicep tendon here. So my question for you, another question is, how do you inject to the distal biceps tendon?
If you want to, you want to inject the distal bicep tendon, I recommend the posterior approach. Yeah. Like
Other approach. The patient flex the maximum flex the elbow.
And you also can do the dynamic scan. And in this approach, is more safe. Yeah.
Is this radius?
Yes.
Yes. And this is ulnar.
Yes. It's safe.
Yeah. Here we can see the biceps tendon, right?
Yeah.
Wow.
Because the brachial artery and the medial nerve is just medial to the bicep tendon. If you inject anteriorly, laterally, or medial artery over here, which is artery, and then the nerve entering the genital tunnel. So you can also to trace the nerve. The radial nerve entering the genital tunnel. There are two common entrapment sites: the arterial force and the exit of the genital tunnel, and the medial nerve. Yeah, and then that is here, and then entering the connector tunnel.
Yes, now we can see a longitudinal view of the median nerve, right?
Yeah.
That's great.
And the longitudinal longitudinal view of the nerve is also important because you can to identify the focal swelling, or you can find a large size.
Okay. Thank you, Dr. Liu.
So much. Congratulations for the second edition of this meeting. And it becomes more worldwide, and I'm very impressed with this Congress venue, and thanks so much. So I'd like to briefly introduce our invented technique for the tendinopathy or other inflammatory disease like osteoarthritis or others. So I hope you enjoyed this talk. And today I'd like to introduce our concept of pain. We call this treatment pain, transarterial microembolization. And also introduce ultrasound-guided simplified pain that is only performed and not using catheter, only using ultrasound and a small needle. And finally, I will briefly introduce application of this technique to elbow joint. So this is brief introduction of our clinic. I invented this technique from 2012, and I opened my own clinic for self-pay clinic in Japan to performing this technique and to spread this technique. And we are interventional radiologists, and so we are not an orthopedic surgeon, but so we do the unique methods, unique strategies for the chronic painful patients. And our main service is the pain embolization procedure for chronic joint pain. And this procedure is like 1 hour or 20 minutes or 1 hour technique. And also do the pelvic pain, bladder, prostate, and also do the embolization for hemorrhoid. And in the other hand, we also do the simplified ultrasound-guided technique, which I introduced today mainly, and also physical therapies and minimally invasive surgery. So this is the total number of our 1 year of the, not recent one, but we performed more than 4,000 cases of simplified embolization technique in our clinic. So the first is the embolization, embolizing the arteries around the joint. That sounds reckless or dangerous, even foolish. I think so. I agree. Is it blood flow necessary for healing? Of course. And won't it cause necrosis or nerve damage, or couldn't it destroy the joint? These concerns are very common and also valid concerns. And this was exactly how we felt, or everyone felt at first. But the important point is that we use temporary embolization. So temporary means several minutes to 20 minutes or 1 hour, so very short. So it's decanalized within the 90 minutes in normal vessels, and then delivered intra-arterially precisely and under imaging guidance. So now this treatment, I came up with this idea in 2007, and first write the first paper in 2013, and now this treatment is increasingly being accepted in clinical practice. Like FDA approved in US for only the NEOA, or only NEOA from 2022, and reimbursed by insurance in Germany since 2023, and many biggest worldwide famous academic hospitals are now doing the clinical trial of this treatment. Let me give you one example. This is a 75 years old female diagnosed with plantar fasciitis, and 1 year history of heel pain and resistance to rest, physical therapy, and painkiller. Affected area is here. So what about the angiography of these patients? So I will show you. This is a normal appearance. This is not a patient, but this is a normal appearance of posterior tibial artery, and you can see the blood flow going to the peripheral. And this is a normal appearance. But compared to this normal appearance, this is angiography of these patients. So you can easily find the abnormal side affected area contains lots of abnormal vessels. We call them blush or moya blood vessels. So this is our target. So nerve vessels, like abnormal vessels, can contribute to maintain the inflammation by many factors. So this is our target, and we want to do the embolize these blood vessels, and by using a temporary embolic material. First, we have several options now, so five or six options. But at that time, in the first phase, I use temporary embolic material like imipenem. Imipenem is a crystalline compound and antibiotics, originally antibiotics, but slightly solved to water, so can embolize inflammatory vessels, microvessels. There are lots of basic animal study about this method, and they're also quickly decanalized in normal vasculature. This is a movie during the infusion from the needle tip of this particle, the small particle which can stuck in a normal artery or abnormal artery. And the left is the behavior of this particle in the normal tissue. Then you can see that in the artery, this crystalline compound once stuck, but the fresh water keeps to come and dissolve within a few minutes. But compared to this normal, in a light-sized inflamed tissue, we can easily find the embolized clogged vessels. So the behavior of the inflamed nerve vessels is different. So the left is before embolization, and right is after embolization angiography. So you can notice that the abnormal nerve vessels blush disappear, and also the normal blood flow increase. So that's the important point. And this patient was very previous patients for the first time for us, and embolization treatment can reduce their pain, and this is a change of VAS score. So you can see the gradually progressive improvement. So the aim is the technique aimed at reducing inflammatory vessels and leaving normal blood flow. That is a very important point. And also I introduced this technique to tennis elbow. This is a paper to JSES in 2017, and we reported the transcatheter arterial. So we use the catheter, super selective catheter method to the lateral epicondylitis, and we reported the good results about this technique. But now we are inventing a new treatment, not using catheter, not using angiostats, but only using ultrasound. I will talk later. But let me briefly introduce our recent paper, the Orthopedic Journal of Sports Medicine, just accepted with Kentaro Onishi, and we work with Kentaro Onishi, and let me give you one example. 24 years old, professional football player, 1 year history of right knee pain, diagnosed as catheter tendinopathy, and already received a lot of treatment, but refractory to that. And we do the embolization treatment, I think for 2 times for these patients. And pain and others decreased dramatically, and he could back to competition 2.5 months after embolization treatment, and 5 years, mostly 5 years has passed. So, but this is the result of conventional embolization. So conventional embolization requires highly skilled catheter manipulation or large angiostats machine, So this treatment is only a limited number of physicians can perform it. So the question is, can we make embolization more easier? We call it the embolization democratization. So what we invented next was no catheter, no angiostats, simplified technique using only ultrasound. So the expands access to pain procedure for more practitioners. in Japan. For example, in Japan, now 129 clinic, orthopedic clinic, have already started this technique. So it's very lots of things. So let's go back to the PTA, posterior tibial artery. You can see that's affected area, and you can see the posterior tibial artery. So if we can directly puncture this PTA, we can shower from the main trunk of PTA and treat this one. So we want to make puncture from this area and then infuse the embolic material. This is our medical device for the simplified pain or Dochu procedure. We call it Dochu procedure in Japan, but the simplified pain procedure. Just like a small needle and extension tube and a small syringe, that's it. And in Japan it's also very cheap, so this procedure requires a very reasonable device. And this is the overview of the procedure. And the physician holds the probe, and the physician punctures the artery, and assistants infuse in the hand. This is cutaneous color change soon after the embolization. You can see the color change and turn to white and turn to red. It means that skin vasculature decanalizes within 1 minute or 2 minutes. This is a video of this simplified embolization technique to the plantar fasciitis. You can see the short axis of PTA, and now you can see the needle tip is inside the PTA, and assistance infused, and you can see the shower crystalline inside the artery. So it takes only 1 minute or 2 minutes. So this is, we usually do not do the angiography, but first 10 cases we use angiography, and we reported this technique results to the foot and ankle surgery last year. So if you are interested in, you can find the clinical results of this procedure. And we also apply this technique to the hand osteoarthritis. There are lots of patients who have suffered from hand osteoarthritis, and as you can see, we can puncture the radial artery and infuse the mechanism from here. And again, the similar, the cutaneous color change like this, and the normalize in 30 minutes. And abnormal nerve vessels disappear, and we reported the clinical data with two reports. One is the TCM joint embolization, the other is the DIP or TIP joint embolization. And from our data, by performing 2 times embolization technique, we can reduce the pain NRS. This is upper one is the before treatment pain NRS. So NRS 7 or 8 or 9 was measured, and 1 year follow-up. Someone doesn't affect, and someone improved a lot, and 75% improved more than NRS 2.4 more in a 75%. And this result was maintained or further improved in a 3 years follow-up. So 70% still have maintained or further improved in this technique. So let me give you other example. This is Achilles tendinopathy, elite sprinter in Japan, top level Japanese sprinter, persistent Achilles pain for 2 years, and a very chronic one. And we can see the Kara-Doppler signal. There is a grading scale of Kara-Doppler neovascularity in the Achilles tendon. This is over score, like 3. That means 2 or 3 Kara-Doppler signal. And pain NRS was 5, and the visa A was a specific Achilles tendinopathy score was 39. And we do this 2 times procedure for him, and NRS was decreased and maintained a long time. And at 4 months later, we could see the disappearance of Kara-Doppler signal. So I noticed that I talked too much, little bit too much. So I will maybe I will skip some data, but we also apply this technique to the trapezius muscle pain. I think there are lots of patients, lots of people who have this symptom, and we reported first we reported the conventional pain, like using a catheter and angiosynth. But we also developed the ultrasound guided transverse cervical artery puncture. And this is a little bit difficult. This is a little bit hard, but you can see the short axis of transverse cervical artery, which is a major feeding artery of trapezius muscle. So the same device. This is the video. Sorry. Maybe you cannot see, sorry. So I will skip, but this is a kind of color change. So if you are interested in, you can find this technique in near future publication. So finally, I will briefly introduce application of this technique to elbow joint. As you know, the tennis elbow is the most common cause of lateral elbow pain, and the most patients respond to conservative treatment, like 80% or 90%, but still 10% or 20% have resistance to the conservative treatment. And the pathological finding of lateral epicondylitis described as angiofibroblastic tendinosis or fibrous granulation containing numerous small blood vessels and perivascular innervation. So, like this. So, similar to the other tendinopathy, we can do this procedure. I will skip this ultrasound research about the symptom with symptom and without symptom difference. And the most severe difference was vasculature. Sorry, but I will skip this. And I will introduce the anatomy, arterial anatomy of the elbow, lateral epicondylitis. The number one is the radial recurrent artery, and number two is interosseous recurrent artery, and number three is the profound humeral artery. These three arteries are related to the lateral epicondylitis, but the most important one is the number one, radial recurrent artery. So I think I can show you the angiography of the tennis elbow, the two types in the several patients. So you can see the brush and at the lateral epicondyle, and yeah. And if you just puncture, for example, if you just puncture the brachial artery and infuse imipenem, the most particle will go to the hand and the peripheral region. So you cannot expect the good results. But by using a tourniquet, and increase the pressure and to stop the blood flow to the peripheral region, we can effectively deliver the particle. This is a movie of the elbow simplified embolization. So the patient puts the tourniquet at the forward arm, and we increase the pressure to 200 millimeter Hg and puncture the brachial artery. It's very easy because the target is very big, and infuse imipenem 1.5 ml. The needle is 27 gauge, so it's very small, and so it's very small. So, and now we release the tourniquet and finish the procedure. This is a very simplified one. And this is the angiography during the procedure. So you can see the blush and of the lateral epicondylitis. If the patients have bilateral pain, like medial or lateral, so you can treat at one time. So by using a tourniquet, no distal flow, and you can see the blush. So recently, the Canon provided a very high quality SMI function to see the abnormal blood vessels. So we tested last week or two weeks ago, and we noticed that this function is very useful for first to identify the neovasculature of blood vessels. So this function is very useful precisely see observe the blood vessels. And we can see after the simplified tummy pain, we can see the small blood vessels and the mainly reduced. So I noticed this function is also useful for confining the delivery of this particle. So we analyzed, this is the data of 2 years ago, but we analyzed the first 59 patients of simplified pain procedure for elbow encephalopathy, including lateral epicondylitis and medial epicondylitis. And I will skip briefly, but the results was 68% significantly improved, but the remaining was not so. So we know that there is a limitation, but we notice that this procedure is good for example, Omotani Sensei combining this technique with prolotherapy. We also combine the prolotherapy and simplified pain procedure for the many tendinopathy. So I hope you can notice this idea and you can begin this technique in near future. So finally, I want to introduce our Congress focus on MSK embolization. So we are now planning to run the International Congress in Tokyo, November, and the most physician is interventional radiologist, but also the ultrasound physician, or rehabilitation physician, or other expertise also will come. And if you are interested in, please scan this QR code, and I hope you enjoy this talk too. Thank you so much.
Told me. Yeah, so there's my teacher. Yeah, so I'm Hatsusan. There is a word, so the Japanese word, ote yawarakani. Ote means your hand. Yawaraka means softer or softer. The means is please go easy on me. Okay, let's go. Today I want to talk about two topics. So what is next, PUT? Next is the US anatomy relevant to PUT for lateral epicondylitis. Because of the co-tester of the Dr. Onishi, I was invited the chance to I've been invited to the Pittsburgh University several years ago. At the meeting, so I really so surprised because there are many devices. I have never seen ultrasound guided surgery devices. So Tenex was one of that. The Tenex can remove the degenerative chain tissues. There's high frequency vibration on the top, and irrigation and aspiration is done. We can use the Tenex machine in Japan now. So in these 3 years, we have almost 50 cases, including very difficult cases. So during Tenex, I can only see like this image. So I wonder what I'm doing. Truly the truth, I thought, it is so effective. So because at that moment I already performed many surgeries, so sometimes surgery is so difficult to reduce the pain. Or it's very interesting because after Tenex, so this is a sponge. You can remove the tissues like this. Sometimes we can confirm the cylindrical defect and tendon. This is a PRV score of the tenants in our hospital. Yes, more than 90% of the patients was so satisfied of that. Recently, many papers of TENX, open surgery and relevant to TENX. So I agree with now. This paper introducing the after we make the void in the tissue, there are new tissue here around the cylindrical defect. It's very interesting. So in my personal opinion, it's very likely to the long punching. So to keep beautiful green long, so sometimes we have to make this use this device to remove the cylindrical soil. So if the normal tissue damage or the degeneration occurred, however, so it occurs in all people maybe. However, usually so it recovered again. So usually we don't have the tendinopathy. Something wrong during this cycle. I have this image. If the house is broken, so we have to first remove the genetic tissues. After that, we can reconstruct. Sometimes there is new cells or blood supply. However, in some cases, there's too many scars. Sometimes many increased vessel flow. However, they cannot heal. In such case, I think sometimes we need to remove the genetic tissues to heal. So yes, get the opportunity to help like this. And next, my important question is that usually, when we talk to TENX or US guided injection for lateral epicondyles, many doctors introduce the long-axis view. However, I wonder, what I'm doing, because as Dr. Lee said, there are many structures, capsule and conjoint tendon, EDC muscle, and superficial fascia. Like very, however, it's very hard to identify the margins between these tissues. So I wonder where now we are approaching. The other problem is that if we put the long axis view, maybe probably the conjoint tendon have the width. I wonder where I'm observing now. So sometimes anatomy application is wrong. So this is not correct, I think. First of all, the shape of lateral epicondyle is very important. It's not symmetrical or round shaped. Usually the length or the long lateral epicondyle is approximately 10 millimeters, and width is 2 over to 3 millimeters. Yes, this shape is very important, and there is a lateral super-epicondyal ridge continuing with that. So here is the insertion of brachial radius and ECRL. So of course, because of this shape, when we put the short axis view to the, if we set the axis to and humeral axis, short axis view, the shape of lateral epicondyle is very small. However, if we observe in this cross-section view, the lateral cutaneous width is wide, approximately 10 millimeter. It's very important. And so the shape of conjoint tendon and so forearm muscle shape changes. So if we extend or flex the elbow joint, so first of all, we have to set the standard position. Usually we take MRI and so extended position. However, I think it's not adequate to evaluate this conjoint tendon problem, because the 90-degree flexion view is so natural. Because many extensor muscle parallelly attached to the lateral surface of humerus. So in long-axis view of conjoint tendon, next, so the axis is means forearm, and in 90-degree flexion. In long axis view, it's very so easy to understand. So sometimes we can easily find osteophyte or classification or something, just the surface or lateral condyle or the lateral aspect of humerus. However, the borderline is unclear. A short axis view, if we observe just above the lateral corner, or usually we find this double force sign, which means that the osteophyte is created just all lengths of this 10 millimeters width, not partial. Usually, so osteophyte has such shape. And if we move the transducer more distally, so usually we can find very thick tendons of tissue. Of course, so sometimes we can confirm increased vessel flow inside this soft tissue. I wonder what's happening. So in the previous many reports says, or here is the insertion of ECRM, ECRB, and EDC like this. However, I wonder, so if the ECRB, our insertion is limited only this area, so why the degenerative change occur in this area? Here is paradox. So there is two shapes of muscle. One is pulsiform muscle, like this, and another is pennant muscle. This is popular, especially in the forearm. So previous research, so their model is like this. However, actually, conjoint tendon is like this. It's different. It's our opinion. So this is a three-dimensional category model. Yeah, so you can see that in the past, previous research says several attachments, so this blue area. I agree that here something is attaching from the conjoint tendon. However, you can see most of the fiber of conjoint tendon attach just all lengths of lateral ectoderm. I think so very important. The upper one is ECRB and lower one is EDC. These two muscles share the same tendon. How to evaluate with the ultrasonography? First of all, so I recommend to observe from the more distally of the forearm. You can see the gamma-shaped structure. Yes. So above the gamma structure, there is EDC, and right side there's ACLV. On the lower side, there's spinator. And if I move the transducer more proximally, so the gamma shape change to this straight shape. Okay, let's confirm it. Like this. Yes, it's a patient. I will so introduce how to identify so each muscle in a demonstration. If I move the transducer more proximally, you can see the amount of cross-sectional area of EDC are getting reduced smaller and smaller. Of course, the EDC muscle volume reducing. And finally, here you can see a thickened soft tissue. I think this is a conjoint tendon. Or this, like this. So the recently, I think the second conjoint tendon is like this shape. So which provides a strong and wide scaffold to ECRB, not only ECRB but also EDC, like this. So if you see this picture, so you can understand, so this structure is not only for EDC, like this, again. Yeah, so this is our opinion. ECR attachment in previous research is very limited. However, we have to evaluate so the clinical differential area. Yeah, so that's so it's necessary to view the entire conjoint extended as a scaffold for the ECRP and EDC. Now, so we so finished the cadaveric research, and so my junior colleague so just submitted our abstract. So then, let's consider how to perform the 10x surgery. So you know that there is a one, so 10 milliliter width, lateral condyle puzzle, 10 milliliter width. So we have to observe this not only long axis, but so short axis is very, very important. And from one extension, we can change the direction to. So usually we need 3 targets, like this. Okay, so finally, so I will introduce this is a typical case. In this short axis view, you can see that so it's no. Yes, very thickened, and you can see a partial tear of conjoint tendon on here. And probably for normal patient, the shape and this shape is perfectly different. So this is a typical short axis view. And the long axis view, because the conjoint tendon has a 10 mm. If I move the transducer anterior or posterior, the shape can change. However, and so you can see this area, the conjoint tendon has a partial tear. Now you can understand this tear was located just anterior side of conjoint tendon. This is the same case after 1 year after 10x. During surgery, the patient so have severe pain. However, after 10x, so the symptoms rarely decreased, and so he is so satisfied. Although there is also fight, and so small changes in the content tendon. However, so let's suppose compare the partial PR disappeared, and you can see that very clearly for partial pattern of the content tendon. So this is my take-home message. One, the text is probably likely effective because it enables mechanical removal of degenerated tissue. So cylinder down 2 millimeter, 2 millimeter.
Speaker is Dr. Winji from Korea. I saw her last year at the conference of the Korean Association of Orthopedic Medicine, KOM. Then I saw her doing the live demonstration for the elbow, right? Yes, her live demonstration was astonishing and surprisingly very well. So I asked her to believe that she can do that. Are you ready?
Yeah, I'm ready.
Are you excited? Okay, let's get started.
Okay, good afternoon, everyone. Thanks for having me here today. And I'm Minji Jung, a rehabilitation specialist from Korea. Today, I will discuss cervical spine. I'm an instructor at the Korean Association of Orthopedic Medicine, KAOM, where I study with many great doctors. And our workshops are very popular in Korea, with more than 400 doctors attending. In 2018, Minagawa Sensei gave a great lecture, and last year, Modani Sensei also gave a wonderful lecture. So following this connection, I'm here with 5 other members, and I'm the youngest one, so maybe that's why I'm in the school now. So let's start with the basics. The cervical spine is divided into 3 parts. And C1 supports the head, and C2 helps rotation, and C3 to 7 manage extension and flexion. So while other facets tilt down and outward, only the C2 and 3 facet joint down and inward, so making it prone to degeneration. And there is third occipital nerve, inner base C2 and 3 facets, which usually make the pain, the cervicogenic headaches. And the facet joint is formed by the articulation of the superior and inferior articular process. The waist is the indented area between facet joints. So the median branch runs above the waist. In the lumbar spine, about 70% of axial loading goes to the disc, but 30% to the facet joint. However, in the cervical spine, the disc and the facet joint share the axial loading equally. So degeneration is slower than the lumbar spine. However, degeneration will happen at the same time in both the disc and the facet joint. So let's move on to the sinovertebral nerve. And the sinovertebral nerve is really important. This is called the spinal pain. The nerve often starts from the both sides of the spine, and it spreads out like a spider web in all directions. It's mostly found at the back of the disc, and you can also find it at the front and around the dural sleeves. As you can see in the figure, if a disc pushes backward like this and presses the dura, it irritates the sinovertebral nerve. So the pain can spread to both sides and affect the sinovertebral nerve at the same time. This creates a bilateral and multi-segmental pain pattern. So when a disc protrudes posterior-centrally and presses the sinovertebral nerve on dura, it causes bilateral and multi-segmental pain. Over time, if the disc shifts to posterolateral side and presses the dural sleeve here, the pain becomes unilateral and segmental. This is called the chronological sequence of the symptoms. So if the patient may say, "Doctor, my neck and scapular pain got better. You're a genius, but my arm feels numb." At this point, you shouldn't think, "I'm treating the patient well and they are getting better and improving." And instead, you should understand that this is a part of the disease progression. Based on these ideas, let's look at cervical spine disorders. So cervical spondylosis is defined as age-related degeneration. And the degeneration itself doesn't cause pain, but pain occurs when the pain sensor structures are mechanically compressed or inflamed. So it shows three main clinical symptoms: axial neck pain, and cervical radiculopathy, and cervical myelopathy. So first one is axial neck pain. So unfortunately, we cannot easily distinguish the origin of scapular pain between the pain caused by disc or facet joint. The diagram on the left here shows the axial pain from each disc level after discography. But the diagram on the right is the mapping of each facet joint after facet joint injection. So as you notice, there is a lot of overlap, so make it hard to differentiate. So next one is cervical radiculopathy, caused by disc and osteophyte. If a patient has neck or scapular pain followed by arm numbness and limited cervical movement, is considered nerve root irritations. So degenerative changes here, and it reduces disc height and cause osteophyte from the disc and uncovertebral joint and facet joint at the same time. So Dr. Sharia distinguished osteophyte from the disc because the treatment is different. Manual therapy is not recommended for radiculopathy caused by osteophyte. The swelling test can be positive in both cases. Last one is cervical myelopathy. It needs to be diagnosed quickly. We need to do an MRI. The earliest and the most common sign is spastic gait. And patients may have trouble with fine hand movement and sensory changes on their feet. The physical exam, limit sign of bone weaknesses, and Hoffman sign can be observed. Okay, move on to the clinic. My clinic is downtown in Seoul, Korea, and with 4 specialists and about 20 staff members. And now let's examine a patient who come to the clinics. When you first see a patient, we check whether they have a forward head posture, spastic gait, or tilting their head to avoid the nerve irritation. We check for any loss of sensation or weakness in neck, shoulder, and both arms. So if we suspect radiculopathy or myelopathy, we need to check the deep tendon reflexes. If there is a radiculopathy, deep tendon reflexes could be decreased. But in the case of myelopathy, there will be a hyperlipidemia. Palpating the painful muscle or facet joint is also important too. Next, we check the active and passive range of motion. In celiacs, divided limited range of motion into 2 patterns. When there is no limitation in flexion, but great limitation in extension, and with equal limits on both side flexion or rotation, equal the full articular pattern. A full articular pattern without pain suggests arthrosis, but full articular pattern with pain, consider ankylosing spondylitis or rheumatoid arthritis. And other limitations are partial articular pattern, and asymmetrical limitations and with greater restriction in side flexion or rotation, such as discodural and discoradicular and facet joint pain. The special test is good for differentiate the nerve root lesion from axial neck. The swelling test is a common way to check radiculopathy, and the extension with lateral bending or rotation with compression is the most accurate. The positive result is radicular pain from neck to arm. If the test causes only scapular pain, it's negative. And shoulder abduction test involves raising the affected arm to see if the symptom is relieved. And neck distraction test checks for symptom relief with traction. And these special tests are highly specific but less sensitive. And if the only sign or Hoffman sign is positive, we should suspect biopsy. Okay, this is the summary. Posterior central disc irritates the dura and causes bilateral and multi-segmental pain. And we can try epidural block. And posterolateral disc or joint osteophyte irritate the nerve root, causes unilateral and segmental and radiating pain with reduced dependent reflexes. And possible weaknesses, sensory loss, and we can do nerve root block. And for intervertebral, oncovertebral, or facet joint problems, it means articular problems. And there are maybe a limited side flexion or rotation for the affected side. And the median branch block or facet joint injection can be considered. And if the spasticity, positive Loomis sign, Babinski sign, Hoffman sign appears, it will be a course sign. Okay, let's go to the practice. And here, the first case, a 29-year-old office worker, right neck and scapular pain. And she had limited extension and right side flexion and right rotation. And Spalding sign was negative, and X-ray showed a loss of cervical lordosis. Her referred pain was in C5-6 area here, neck and scapular. So, suggesting axial neck pain. Since she was young and had pain with specific movement, we performed a C5-6 median branch block as a diagnostic one, and afterwards, symptoms are getting improved. The extension and right side flexion and right rotation could see the improvement. About the median branch, it runs slightly above the waist. So in the longitudinal view, the lowest point corresponds to the waist. For median branch block, we typically use a transverse view. So insert your needle from posterior to anterior. About the facet joint injection, in the longitudinal view, the highest points indicate the facet joint. So we use a transverse view for injection while confirming that the facet joint opens up in the direction of the needle. Insert your needle from posterior to anterior. The second case is a 43-year-old professional gamer with tingling sense and numbness on the right shoulder and lateral aspect of elbow. So right spurring test worsened. And the abduction test relieved symptom. The biceps jerk was reduced. And reduced shoulder abduction and abduction were slightly weak. The X-ray showed the C5-6 disc space narrowing. So we performed C5-6 perpendicular block, and the symptom was gone. Okay, this is the important things. For a conventional radicular block, we usually inject near the posterior tubercle. However, this method often lacks long-term relief compared to epidural block. So this is because posterior tubercle is outside the neural foramen and far from the epidural space. So making it difficult for the medication to reach to the epidural space effectively. So to address this, Dr. Sun-Gyu Che, a neurosurgeon and a brain mentor in our association, suggests a new method. Many doctors in our association are using this technique for injection. So here you can see 6 vertebrae here, and anterior and posterior tubercle, and medial voltage. Now you can notice the posterior tubercle is far from the neural foramen. So when we injected the posterior tubercle here, it's really far from the neural foramen, so it would be hard to deliver the medication to the epidural space. So on the right image, there is a blue mark on the posterior tubercle. So it's a conventional injection site. But when we move here, there is a pink line. This is the superior articular process. So when you clearly see the superior articular process is significantly closer to the neural foramen. So compared to the posterior tubercle and superior articular process, this one is much closer to the neural foramen. So we suggest inject here to deliver the medication to the epidural space. So by moving the probe over from here to here, slightly from the posterior, we can observe the superior articular process. Now let's see. So let's move the probe from posterior tubercle to superior articular process. On the ultrasound image, the anterior and posterior tubercle of C6, and by moving the probe slightly upwards, both tubercles disappear, and at the same time, a flat bone here appears, this one, the superior articular process at the level of articular pillar. This is the superior articular process. As the tubercle disappears and the nerve root will move inward toward the neural foramen. Again, as the posterior tubercle disappears, nerve root moves downward. And with Doppler, we can see pulsating vertebral artery along with the neural foramen. So from anterior to posterior, there will be vertebral artery and neural foramen and superior articular process. So from anterior to, so we are going to inject from posterior to anterior to the very end of the superior articular process. So this is the video of Dr. Seok Hee-hong, a neurosurgeon well known in our association for his beautiful injection skills. So you will see the posterior tubercle. Let's start the video. So now you will see the posterior tubercle only. This means this is 7 because there is only a large posterior tubercle and anterior tubercle is disappeared. And move the probe upwards. There is a C6, posterior tubercle and anterior tubercle here, posterior and anterior tubercle C6 nerve root. And move the probe a bit more. You will see a superior articular process at the level of articular pillar here. So let's move up the probe. Here you can see. This is superior articular process. Where are we going to inject? So let's inject the needle from posterior to anterior. There is a needle coming from the posterior, and lock the needle to the very end of the superior articular process like this. And then deliver the medication. Now you can see the medication is flow down to the neural foramen like this. Okay. And move on to the next page. And Dr. Young Jun-mo is coming here. And another neurosurgeon conducted a study comparing the traditional method with modified technique of ultrasound-guided cervical nerve block. And he made the injection from posterior tubercle, the cross mark here, and superior articular process, the triangle, and the end of the superior articular process is the circle. So then he confirmed the medication spread using a CR. The result is clearly show that the closer we inject to the neural foramen, it means the end of the superior articular process. That's one circle. and the better medication spread to the epidural space. So this is the references, and thanks for listening, and I will show the on the demonstration. Thank you.
Thank you.
From there, you can palpate articular over the neck. So start with the foot, longitudinally, below the massage process. When scanned from longitudinal view, it's really important to find the unique shape of C2. You can see hyperboreal line here. This is the sharply floating downward. This is C2 lamina. So it's really crucial to identify the unique shape of C2 here. And from here, you can see the facet joint. To move the probe downward. You can see the facet joint here. And between the facet joint, you can see the indentation. This is the waist where the medial branch exists. So now you can see the repeating pattern of facet, waist, and facet, waist, like this. So if you want to inject that, just use 4 or 5 facet joints and count down from C2. The sharply sloping down the C2 lamina and C2 facet joint. And over there, you can see a hyperboreal line shape. This is the third occipital nerve. And go to 3 and 3, 4. And move down to 3, 4, 5 level. And from here, we rotate the probe, ensuring do not lose the joint sleeve like this. And move and rotate here. And from this view, the posterior is on the left and anterior is on the right. And the facet joint is angled downward, so the joint sleeve here, narrow, is open anteriorly at the top of the joint. And when you move the probe downward, the joint sleeve opens posteriorly at the bottom. So when you freeze, you can inject from posterior and anterior to the joint sleeve. And when you move the probe up and down, and you can see the variations of the bony cortex. The highest point is corresponds to the facet joint, and the lowest point here is corresponds to the waist. From the waist, here you can see semi-spinalis cervices attaches to the waist. And semi-spinalis capsus is the pelvis. And can you see the pulsating artery here? This is the deep cervical artery between these two fascia. And medial nerve runs between these two muscles, semi-spinalis cervices and capsus. So when you do injection and put the needle from posterior to anterior to the waist like this. But if you have a patient with arthropathy, it's really hard to find the waist correctly. So in that case, you can just inject through the fascia line between the spinal cervices and capsus. Okay, then let's move on to the cervical nerve. From here, let's find the cervical nerve. Put the probe just over the sternocleidomastoid muscle at the level of cricoid cartilage. Because cricoid cartilage usually correspond to the G6 level. So put the proof here. There is a proceeding carotid artery, and you can see a claw-like shape of anterior and posterior tubercle. On the screen, the posterior is on the left and anterior is on the right. You can see a G6 nerve root too. And to confirm the nerve root and the level, and you move the proof to downward. Here, freeze, and you can see the large posterior tubercle only, and there is a system nerve root, and anterior tubercle is disappear. And with Doppler, you can see proceeding vertebral artery, well, the anterior tubercle is supposed to be. You can confirm C7. And then move the proof over. There is C6 because there is a large anterior tubercle here. This is larger than the posterior one, and C6 nerve root. And forming a large U shape in the tubercular groove. And move the groove over and see C5. And there is a similar shape of anterior and posterior tubercle and forming smaller groove. So for conventional nerve root block, let's find the C6 posterior tubercle again and pull the tubercle to the injection site and freeze. So we usually inject the needle and touch the posterior tubercle and advance anteriorly and deliver the medications under the nerve root. But this is a limitation because it's far from the neurobrain and it's harder to deliver the medication to the epidural space. So we suggest modified technique. Let's start. And this is C6 posterior tubercle again. And move the proof over slightly. The posterior tubercle will disappear like this. And at the same time, freeze. There is a superior articular process here. And we are going to inject to the very end of the superior articular process. And I will explain the technique later. And then go back to C6 posterior tubercle again. And when the posterior tubercle will disappear, there is a C6 nerve root. So because of the setting, the nerve root is not clear. This C6 nerve root is moved downward when the posterior disappears. Move the proof words like this downward. At the same time, there is a vertebral artery here. So this is the vertebral artery, and this is the neural foramen. This is for your articular process, and we are going to inject here. And what is the walking technique? And put the needle from the posterior and touch the spine and slide, and touch the spine and slide until you can reach to the very end of the superior articular process. This is why there is a ligament above the superior articular process. So if you forcefully push the needle through the ligament, you can still stop and the medication won't flow. So go to the very end of the superior articular process, like this, and deliver the medication from here. For sure, you have to check the Doppler. And then you get the medication to the epidural space. This is my demonstration, and thanks for your attention.
And TOS staff and many companies. And today I will discuss the use of US of the lumbar spine region, which I have found to effective. Although it's not maybe latest, I hope this presentation can be of some help to you. First, introduce myself. My name is Hiroki Katayama. I'm spine surgeon. I'm relieved finally in my field of, I'm spine surgery. So, my strategy of the spinal pain is first I took the physical examination and I do the diagnose injection or hydrodissection or block, and then the pain relief is not so much time, so I do the RF or PRF treatment. The injection was effective, but it does not provide long-lasting pain relief. I perform the radiofrequency ablation or pulsed radiofrequency ablation therapy. PRF on the RF needs these guide needles. Then move the inner tube and insert the electrode. This is electrode, and then emit the heat or pulse electrical stimulation from needle tip. Then move the needle closer to the target nerve, and the same way as the injection. And we took the test stimulation to confirm that the needle is near the target nerve. Confirm that the nerve pain appears at 0.2 volts, and then nerve stimulation is started. The RF and the PRF did the same but the different therapy. RF causes the thermal degeneration of the nerve at the 80 degrees Celsius. Therefore, it used on the sensory nerves such as the joint branches. In contrast, the PRF does not cause the thermal degeneration, and that can be used for the motor nerves, such as the lumbar nerve root. So this is there is good evidence for the nerve root and the cervical spine. There is also evidence for the discogenic pain. So here is today's content: the facet joint and so on. So I have very difficult problem in my lumbar spine practice. That is how to treat the non-specific low back pain that cannot be detected by imaging. So even if the qualitative evaluation is not positive, diagnostic work and using US can be used to attack the low back pain. You can deal with many types of low back pain by US. So let's start with the review of basic anatomy. The posterior muscle groups are arranged in this manner. From the medial side, the multifidus muscle, longitudinous muscle, iliocostal muscle, and this is QRB. Level diagnosis is important to observe the spinal column. The QRB is the QRM is characterized by the originating from the iliac crest to the attachment to the T12 limbs. It is easy to identify the elevation level of if you can identify the quadrilateralis QRM. The first step is to locate the QRM and then move the transducer separate to identify the lowest limb. And the second step is to follow the limbs to identify the lowest thoracic vertebra. From there, the L1 and L2 vertebra are counted to make level diagnosis. This called the square technique. Check the bone is like this. Now you put the transducer right here, and this is the transverse process, and this is facet joint, and here is the multifidus muscle and longitudinous muscle and iliocostal muscle. QRM attached to the transverse process, and so you can see this muscle, this like the dolphin. This is the QRM. So you put the transducer, go to the cephalad. The muscle is very shorter, thinner, and this bone structure is come from. This is the T12 lowest limb. So you can check the lowest limb attachment, and the vertebra is T12. So, and go distal to the probe move goes distal, and this is L1 and L2. You can check this way. You can check the level this way. Long axis approach is better, but this way. This is the articular, superior articular process is here. Here is the strap line of the sacrum, and the L5S1, L45, and the L35 like this. You touch the PSIS like this, and place the probe inside it. The facet joint shape like the camel's hump can be visualized like this. So you can check the level from here. So first discuss the facet joint pain. As a facet joint pain is mainly unilateral with the high frequency of the back pain during back bending, like this approach. I check the patient from the like here, the bending and rotation technique. So that this motion forces make a forces in the facet joint, I think. When the facet joint is suspected, the US of the facet joint may show swelling, osteophyte, and increase the blood flow as shown here, but they are not count on we cannot confirm the diagnosis of their own. So unique way of making findings in US sonopalpation. I use this sonopalpation in addition to the previous findings to determine to the level of the disability. This is sonopalpation. And there are the inline or outline approaches. The approaches depend on the shape of the target facet joint. Use the out-of-line approach most often. I use the most often. I think that just like this. So the needle precisely inserted into the facet joints. I'm sorry. Needle comes here. Enter the joint. The joint capsule is bulging. So this way, yeah, we can check the exactly into the intra-articular injection. He is the patient who suspected facet joint disorders. If you pain like this, opposite side is not. So eye injection here for his facet joint. It's nothing. Yeah, very good improvement. So this patient's pain comes from the facet joint, I think. So I believe that injection can help diagnose back pain comes from facet joint. However, if the effect of the injection is not sustained, what is the next step? Surgery for facet joint pain is not performed in Japan, and if the rehabilitation doesn't work, so what is the next treatment? So I use the radiofrequency therapy. This is a procedure that the denervation nerve around the facet joint from the facet joints. RF mainly targets the posterior only using the fluoroscopy, but we can also do the ultrasound. RF treatment that burns the nerves, the target must be more precisely targeted in the more than in normal injection. Let's get the anatomy. So those are lumps of the spinal nerve. The posterior branches, that's divided into the medial and the lateral branches, like this, medial and the lateral branches. They run into the body of the intervertebral joints and transverse process. These medial branches feeding the facet joint. So medial branches has the multifidus muscle and the facet joint. Lateral branches innervate the longest muscle and the intercostal muscle. So we need to isolate these two for RF to prevent muscle atrophy. So the most common US guided injection of the dorsal lumps is performed this manner in the short axis view, and outer of the facet joint here lands from the nerve, both nerves. So do the injection from here, but the medial branches runs between the papillary process and the accessory process. So there is a ligamental structure between the memory process and accessory process. This is the anatomic image and the schema like this. The medial branches passes under this ligament, lateral branches here. So we need injection medial branches selectively. For this purpose, it is important to apply US that mimic the learning of the mammal accessory ligament like this. People that probe this way, they slightly twist the mammal accessory ligament learns. If you cut the anatomy atlas in this view, the posterior medial branch learns like this. When the combined with the US images, it looks like this. This is mammillary process and this is accessory process, and here is the medial branch. The actual nerve cannot be visualized, but the location of its presence can be confirmed by looking at the companion blood cells. So now, actually, I performed RF. It can be confirmed only the multifidus muscle is stimulated by the electrical stimulation. I injection here, and I stimulation the nerve. Injection here, and during electrical stimulation, you can see only multifidus muscle is working. So that is so I selectively injection. And next step is the SIJ. The sacroiliac joint score is useful for diagnosing sacroiliac joints. This method uses these evaluation items. 4 points or more is considered positive. The cases is the sacroiliac joint score is 4 or higher, as described earlier, then given the diagnostic injection to the diagnostic sacroiliac joint. At first, the injection of the posterior ligament performed, and then you do the intra-articular injection. The diagnostic sacroiliac joint disorder is made when the pain relief is achieved. This is the echo US images. I'm sorry, this is not work. She is the SIG pain occurs around the PSIG lesion, and when starting up from the sitting position. She has SIG score is the 4 points. She said in the when standing, she feel pain in the PSIS. So I do the hydrodissection into the posterior ligament. This is PSIS in the sacrum, and this is the posterior ligament. After that, her pain was
It's smooth at all.
relieved.
Like, it's completely different from before, isn't it? That's not true. How many points? How many points? It doesn't really go.
I'm sorry, this is AI stimulation, AI translation. She said that very good pain relief. I'm sometimes troubled that causes which the posterior ligament injection are effective but do not continue to the relieve pain. In such cases, I performed RF of the sacroiliac joint branch. So the injection just described the say to the the injection just described is said to the act on the nerves within the interosseous ligament below the short posterior sacral ligament. This is short posterior sacral ligament, and this is the interosseous ligament. And in this, there is a nerve, many nerve, I think. So this area of sacroiliac joint, they said that the joint branch of the posterior branch of the sacroiliac joint emerged from the posterior branch of spinal nerve, like this. That the US guiding RF has been reported as shown as this paper, like this, from here, this X points. I place the probe in the long axis view, and the needle guiding the S1 posterior branch, sacral foramen. I insert here S1 spinal foramen here. S1. So I injection here and stimulation here, and RF, I do the RF here. After that, the patient pain is very clear. The RF for the SIG joint is very popular and have very good evidence in the world. So this patient come, and another patient complained of severe pain. He moved his leg in this way.
右側と言いつつも、ここお尻、骨、
Like this. He
上
said,
げて、
"Ooh,
下ろすとき。
ooh," like this.
ね。
This pain is I think the most occurred from the intra-articular synovial pain. So we consider these cases the intense pain with the weight bearing or the pain active in the active SLR. I do the intra-articular injection. When put the probe into the sacroiliac joints, go down to the distal. This is ilium and this is sacral. The ilium and sacral is the same level. This is the sacroiliac joint. And I injection like this out of line approach. Here is needle tip. And the solution spreads like here, this. That solution spreads. So after that, he was able to move his leg
今痛くない。
with great
さっ
ease.
き寝転がるだけでも、うーっと言ってましたもんね。反対側どうですか。これも今
So not all cases allow the US guided intra-articular injection in this manner. In some cases, fluoroscopy must be used due to this osteophyte formation. So please refer to the Dr. Kurosawa's paper on fluoroscopy. Further research is needed to be able to perform this type of injection in the US. You can see the sacroiliac joint practice flow. If the posterior ligament injection works, but it's short duration due to RF of the posterior branch, it is difficult to stand. I do an intra-articular block. The pathology is that the former is the symptom of the nerves outside of the joint. The later is considered the pain in the synovial membrane or free nerve endings in the joint. It's a concept such as the knee. Returning to the diagnostic block, for the sacroiliac joint is so that if the sacroiliac joint block is ineffective, other causes should be considered like this. What is the other causes? Control that was positive for the sacroiliac joints. The alternative causes is like this: L1 S1 facet joint, L5 S1 disc, S1 root, superior cuneal nerve, and Bertolini syndrome, and so on. But there is still symptoms organizing from the sacroiliac joints. I would like to mention third injection in the target of the middle cuneal nerve. This paper discusses the learning of the posterior branches of the sacral level. Those are lumps of the spinal nerve learned under the long posterior sacroiliac joint. Distal to this the middle. This is the middle cuneal nerve that becomes. This middle cuneal nerve has been reported to entrap in the long posterior sacroiliac joint. Counter-nutation of the sacrum leads to the elongation of the long posterior sacroiliac joint ligament, which is considered to cause the irritation of the middle cuneal nerve located beneath it, like this. Lectured with US, the PSIS learned between PSIS and the PIS. So place the probe like this. So then the US image like this obtained. This is depicted the schematic diagram. The MCN should be located ventral to this ligament. Also, it is difficult to delineate the US images. We actually compare the injection to the posterior ligament injection and anatomy class. This is clear that the chemical has spread to the distinctly difficult side. This is the posterior ligament injection, and this is the middle cuneal nerve injection. This patient has the SIJ scores 4 points, but the buttock pain is ineffective. Butt block was ineffective. Therefore, that we perform the block and the PRF in the middle cuneal nerve position.
What can I say? The pain here has disappeared. Somehow it depends on the day.
The pain has disappeared at the 80%. The effect has lasted for the more than the 6 months. ちょっと時間がないので、and the time has come, so I avoid ちょっと切ります。Cut the epidural blocks. So moving on the next term about nerve root block. ちょっといいですか、hands-on の時間削って。Next, we will discuss the nerve root blocks. Neurologic back pain with no lower extremity pain and only no back pain, and the nerve root disease with the poor imaging finding is known to exist. To avoid overlooking such cases, it is necessary to confirm muscle weakness in all patients with low back pain. This is the movie. I do the very slowly muscle weakness, check the muscle weakness, the strength of the muscle, so that the patient supports very, very clearly. All low back pain patients, I do this MMT check. Using the fluoroscopy of nerve root block in all cases is not practical. So therefore, the ultrasound guided nerve root block useful. It offers the advantage of being performed immediately in the examination room. There are various papers, but none of them provide clear conclusions. This paper uses the transverse process as a landmark. However, rely on the transverse process and landmark, sometimes design is this type of needle placement here. A contrast of the yoking outside. In the ultrasound, transverse process appears like this and shows no distinct change in shape, make it less reliable landmark. So we need to the clear landmarks such as half mountain view. This is useful as the Merkmar indication of the outer of the intervertebral foramen. It is characterized similarly to the MRI parasagittal view. The good thing about this method is two. It allows the neurography and it facilitates level diagnosis. The common short axis method tend to the misdiagnose elevation. In addition, because it resembles the sagittal image of MRI, the level can be confirmed from the difference to the MRI image, even if degeneration is strong. So, in fact, I do this approach, touch the PSIs and put the transducer inside it. This is the sacrum, and here, this is sacrum, and here is S1 and S2 foramen. S1 and S2 foramen. So, put the transducer, move to the posterior. Here is the L5 lamina. This is the superior articular process and inferior articular process. Move the transducer, go outside. This is SAP, and this is the basis of the accessory process, and this is the pedicle, and this is half mountain view. Like this, the lice. And here is the nerve root. If you translate the half mountain view roughly into Japanese, my name is Katayama. This is Katayama view. Please remember. And the MRI fusion function shows that is high echoic region caudal to the half mountain view is the nerve root, I think, like here. When using root block, this bony landmark indicates the intervertebral foramen. Therefore, the injection can be made based on this landmark, even if the nerve is not visible, like this. Like this. if you look at this dissection, you can see that injecting in the caudal side of the vertebral half mountain view allows the drug spread of the nerve root like this. So I did research 2021. This is the method of confirming the puncture site by fluoroscopy immediately after US guided nerve root block. Half mountain view has able to puncture immediately compared to the previous US approach, and the position of the puncture was comparable to the fluoroscopic method. There was no differences in the duration of the pain relief. Actual injection, like this. I do the MMT physical examination, and I do the injection like this. After injection, he can run. So this immediately effect is very great, and it would be great for the US guided lumbar nerve root block, I think. Since the nerve root roughly 5 centimeter deep, injections were made using the crossing out of line method with the 78 degree. In the less degenerative changes, degenerative cases, even the nerves are clearly visible. In practice, however, this is the case with such strong degenerative are difficult. In fact, the degeneration makes it impossible to injection the half mountain view. For this region, we inject just outside of the half mountain view. Here is sacrum, and this is L5S1, and this is L45 region. This is very near because of the degenerative change. So I put the transducer a little bit lateral. Here is the just outside of the half mountain view, and I do injection from here. In fact, it is not always possible to inject just by US, but I personally, using fluoroscopy patient is the 1 or 2 people a year. This patient is like this, and I have many slides, but the time has come. I'm using the failed back surgery syndrome for surgery syndrome, using the nerve root PRF, a very great outcome. And discogenic pain injection was the next time, I think. Please invite me. This is Toru Omotani's paper and me. From lateral side, using the US, you can see the injection like this. You can see the intra-discal injection like this. Thank you.
Yeah, thank you for the nice presentation. I know that you have much things you want to talk about this in this Congress. But you know, after this lecture, you have a time.
I'm Shuhei Iwata from Chiba University, and thank you for this opportunity. And please feel free to ask me anything at any time. And I'm looking forward to having discussion with you. I'm from Chiba, and Chiba Prefecture is located next to Tokyo, and it's well known for its mascot Chiba-kun. It's a dog shape and character inspired the shape of Chiba Prefecture itself. And the right photo is Chiba University's photo, and where you can see the beautiful cherry blossoms. And I love baseball, and I have practiced so hard, and finally I developed lumbar spondylosis myself. And sometimes I'm suffering from low back pain, but I'm a positive person, so I haven't developed chronic low back pain. And this experience got me interested in spine and pain, so eventually let me become spine surgeon. So right now I have 3 roles. First, I'm a spine surgeon. Second, I'm a team doctor of Save Lions, a national professional baseball team. And I'm a PhD student, and I'm conducting a research about pain and the brain. Here is a summary of my background. And from this August, I will work as a postdoctoral research fellow in US, University of Minnesota. So let's start. Today's content is about low back pain and gluteal pain, especially in young athletes. So there are many causes of low back pain and gluteal pain in young athletes. For example, lumbar disc herniation, spondylosis, piriformis DGS, or something like that. So today I'll talk about the following contents: spondylosis, disc herniation, discogenic pain, Bertolotti, deep gluteal syndrome, and future research. So first, spondylosis. Spondylosis is a stress fracture of pars interarticularis like this, and it can become severe and lead to spondylolisthesis. The symptom is localized low back pain on one side and extension or lateral bending pain, Kemp test positive, and sometimes buttock or lower limb symptoms. The prevalence in the general population is approximately 6%, with 80% of those cases being bilateral. Among athletes with low back pain, 42 to 47% have lumbar spondylosis. The stage is made based on CT or MRI, and the bone union rate depends on the stage. Very early or early stage, the bone union rate is approximately 90%, but it takes 2 or 3 months. And the progressive stage, bone union rate is 23 to 64%, and it takes half a year. And the terminal stage bone union rate is 0%. It's a horrible and terrible disease. And its progression to spondylolisthesis is bilateral side 75 to 90%. So treatment goal is aim for bone union, or preferably at least unilateral union, and sometimes shared decision making for sports continuation. The treatment option is conservative treatment, rest, rigid brace, physical therapy, and now I practice and perform extracorporeal shockwave therapy, ESWT. ESWT, as you know, there is a guideline or ISMST, and I use Focus ESWT. I have performed 83 patients, 122 lesions, like this. And shockwave direction is slightly cranial and lateral, and avoid targeting spinal canal. And shockwave direction is like this, sagittal and axial, cranial and lateral. I perform every 2 weeks until getting bone union. And how about ultrasound in spondylosis? There are 2 papers. One paper is from Nagoya University. Early stage sensitivity 90%, specificity is 77%. The second paper is extraosseous signal change of MRI and ultrasound. So how to evaluate? And I have made some ATFL papers, and I usually explain the fibula and the talus, like this sphinx and pyramid. I use this sphinx pyramid to the lumbar side, like this, sphinx and pyramid. As you can see, this is lamina and facet and spondylosis. In early stage, blood flow to the pars defect. But healthy side, blood flow is limited, just one artery. So case 1 is 17-year-old male, L3 unilateral lumbar spondylosis. I performed ESWT 4 times and brace in just 8 weeks and returned to baseball. Our next progressive spondylosis in like this. The progressive stages, blood flow is very limited. And you can see the gap of the bone. Now after the ESWT, blood flow increases. And this case 2, 15-year-old male baseball player, L4 bilateral progressive lumbar spondylolysis. I performed 6 times and braced just 12 weeks and returned to baseball. So this is the result summary, and compared to previous reports, bone union rates is higher than previous reports, and the duration is shorter than previous reports. So ESWT is a mechanical stimulation of bone tissue, and it believes that tissue micro damage promotes growth factor or angiogenesis and induces cell proliferation and accelerated bone differentiation. And spondylolysis in the sports, 98% of athletes with spondylolysis return to previous level within 3 months, but about 20% require block injections. Block injections include pars interarticularis, superior facet joint, inferior facet joint. So I use these 3-point block injections. First, pars interarticularis. Second, superior facet. In this case, L4-5 facet. And inferior facet joint. In this case, L5 S1. So, summary: ultrasound and ESWT is essential for lumbar spondylolysis. Next, lumbar disc herniation. Lumbar disc herniation causes leg pain, and straight leg raise test (SLR test) is essential. L4-5 herniation mainly causes leg pain, but L5S herniation sometimes present with only buttock or gluteal pain. And you can see that nerve root is swollen and thickened due to inflammation. And S1 nerve root block injection is an effective treatment. We have conducted 3D anatomical studies to support S1 nerve root block injections. S1 neural foramen is visible if the cranial 30 degrees. So in the fluoroscopy, align the fluoroscope to the center of the spinous, S1 spinous, and tilt the fluorescence cranially to align the S1 upper end plate. And if necessary, place a pillow under lower abdomen to reduce lumbar lordosis. Like this. But using ultrasound, it's easier to find S1 neural foramen. Right here. So we can use a probe, and ultrasound guided injection is easier than fluoroscopic. And drug composition. I made some research about ultrasound-guided cervical nerve root injection for CSR, steroid versus non-steroid. And I checked NRS from baseline to post date 14. This is not S1, but C6 nerve root block. The result is like this. The steroid group is getting better NRS score. So the analgesic effect may involve not only direct action of local anesthetics on neuropathic pain and improve nerve mobility through neural environment, but also anti-inflammatory effect that suppress nerve root inflammation and prevention of central sensitization due to long pain blockage. And is that MRI showing a simple lumbar disc herniation? No. With apophyseal ring fracture, surgery may be considered. And this surgical video also shows that the nerve itself is inflamed. This is nerve root, swollen, inflamed, red color. Now remove the herniation. And with, I think, the TNF and the VEGF, so new vessels are there. Okay, next, solve discogenic pain. Discogenic pain's feature is forward flexion pain, poorly localized pain area. The pain occurs both while sitting and with movement. Sometimes chronic pain, low back pain with anxiety or depression. Discogenic pain is from damage to the annulus fibrous and nucleus pulpus move to posterior and increasing instability. It's leading to chronic low back pain. The chronic inflammation causes high intensity zone, HIZ. And the nerve growth is occurred around the disc, and there are inflammation including TNF-alpha, IL-6, VEGF. So I sometimes perform epidural injection. This is epidural space. It's very easy. Or sometimes using fluoroscopy, epidural injection or PRP injection into the disc, or using ultrasound. Professor Omotani's paper is famous. It's a Curious 2023. Next, Belt-Rot syndrome. Belt-Rot syndrome is a cause of sacroiliac joint pain associated with the lumbosacral transitional vertebra, LSTV. The prevalence of LSTV ranges from 6% to 24%, and mechanical irritation causes chronic inflammation. There are many types of lumbosacral transitional vertebra, LSTV. This is a 24-year-old national professional baseball player. He has L6, and he has Belt-Rot syndrome. And MRI shows this left side transverse process is bigger than right side. And this is the actual MRI and forming the joint with SDIR high. So I performed the injection using ultrasound. Between ilium and sacrum, there were L6 transverse process. So injection is around here, 2 ml of lidocaine and 10 milligram of triamcinolone. And in this case, fluoroscopy is also useful to adjustment into the area forming the joint. Last, deep gluteal syndrome. Deep gluteal syndrome, DGS, is a sciatic nerve disorder caused by compression of the sciatic nerve in the piriformis or deep gluteal muscles. This is a surgical case. Removal of piriformis muscle. After the surgery, sciatic nerve is released. There are many diagnostic tests. Freiberg test, PACE test, and Betty test, prone internal rotation test, and active performance test. But since it is difficult to make a diagnosis based on just a physical examination alone, MRI for lumbar spine and diagnostic injections are essential. So sometimes lumbar disc herniation, the diagnostic test is positive, and sometimes SLR test is positive in DGS. So using ultrasound, we can check the peripheral muscle and the sciatic nerve like this. And we can palpate like sonopalpation, US guided palpation. But sciatic nerve hypersensitivity and positive findings may occur even not only in DGS but also in S1 nerve root disorders caused by L5S herniation. So hydro-release by 0.1% lidocaine or around the sciatic nerve, or 10 milligram of triamcinolone into piriformis, I perform this kind of injection. Lastly, future research interest. US guided injection and spine surgery are very effective, but sometimes patients have pain even after treatment. As a spine surgeon, I want to be active in not only spine surgery or injection, but also basic research about pain. So 20 years ago, it's basic research, innovation, information. 10 years ago, clinical research and sagittal alignments are focused on the spinal research. But in the future, utilization of ultrasound or visualization of pain and brain is coming. I love this biopsychosocial model, BPS model of pain. I think that when I break down the BPS model in more detail, I think it looks something like this. And it has become clear that not only sensation and cognition, but also emotions such as pleasure and discomfort play a significant role in pain, especially for low back pain. And when tissue damage occurs and it causes pain, but without fear and cope with pain positively, it can cure. So I don't have chronic low back pain. But negative feeling or bad information cause wrong way of thinking about pain. And with sleep disorder, fear, depression, the pain is getting worse and the chronic pain. And I'm working as a baseball team doctor, so the importance of mental health is increasingly being recognized even among athletes. So during this spring training camp, I performed 100 professional baseball players question survey using Smart One by IOC. So the results, athletes with higher ADHD scores experience low back pain more frequently and with greater severity. And sometimes patients with chronic low back pain who are resistant to CBT tend to have higher ADHD scores. So the dopamine regulation plays a significant role in low back pain. So this BPS model is very important to treat low back pain. So let's collaborate and do our best to uncover the complex mechanism of pain. Thank you so much, and please keep in touch. Thank you.
Thank you for your presentation, Dr. Iwata, and the various topics from the spondylolysis to the Bartter syndrome and also the brain and ADHD, some other topics. Thank you. So we have time to go to the hands-on session for
basic ultrasound imaging and some of the ultrasound guide intervention. So the topic's gonna cover. The topics usually gonna cover 4 aspects of the knee. I cannot cover all of it, but basically with the knee is some of the structure is superficial, so it's very easy to use with the ultrasound. First, I will do anterior view for a structure that is going to be focused, which is quadriceps tendons, patellar tendons, and the trochlea of the articular cartilage, and the joint of fluid. And we go to the medial side, which is going to cover MCL, and then PES, and then meniscus. And next, we'll go a little bit for the posterior and check the meniscus. And we go lastly to the lateral view, check the LCL, ideal tibial veins, and lateral meniscus. Okay. Basically, actually, you can scan a lot of things. You can even scan the cruciate ligaments, but it's going to be 2 hours. So we're going to only do this one. The first one is the anterior view. Every time I scan my knee, even though the patient comes with medial knee pain or lateral knee pain, I always scan the anterior view. This is someone called the home base. The anterior view, we give you pictures of the overall qualities of the knee. What will you see in the anterior view? Basically, you see the nice quadriceps tendon, which contain 3 layers: superficial layers, intermediate layers, and deep layers, which come from each muscles of the quadricep. If there are any pathology here, you might see some calcification, which usually might be because of the old injury and usually not causing pain. And if you look a little bit deeper, you will want to check the effusion. The most common position to check effusion is the anterior view. Usually you will see possible effusion between the suprapatellar fat pad and prefemoral fat pad. This is a physiologic effusion which is considered normal. However, if it's like a very hypoechoic and echoic effusion here with a lot of hyperechoic effusion, hyperechoic synovial here, which usually came from chronic osteoarthritis or some rheumatologic disease. With this kind of effusion, you might see that there's a lot of effusion in the knee. However, if you do a blind injection, it might be challenging because there's a lot of synovial here as well, and it's possible that your needles blindly go into the synovial and you might think that you cannot aspirate the knee joint, even though there's a lot of fluid in. And this why the ultrasound guide aspiration is more superior than the blind injection. Okay, so the recommended and the most popular site of injection is the suprapatellar recess. So usually you scan on the longitudinal view and you aim at the suprapatellar recess here. And this is the quadriceps tendon with the prefemoral fat pad. Usually we do the in-plane technique in the transverse view, but just check at the always check at the longitudinal view also whether you are at the right spots here. If the patient has very less effusion, it's going to be a little bit challenging, but if there's a lot of effusion, it's easy. Okay. The next step after the anterior view, I recommend you to go to the toe clear cartilage. You go maximize of the flexion, knee flexion, and you put the probe transverse at the top of the knee. The things that you're gonna see is the articular cartilage here in hypoechoic. With this black hypoechoic area, you might think of a fluid, but if it's a very nice hypoechoic, it can be cartilage as well. So basically with this position, you will check the articular cartilage of the toe clear like this. Above it is the quadriceps tendons. What information you will get from this? First of all, you can get a lot of information if there's some deposition in the toe cartilage. Usually the most common one is the CPPD, which is calcium pyrophosphate dihydrate deposition here. And right now I'm more surprised that we see a lot more in younger generation with the CPPD and the gout deposition. It has 80% sensitivity, so if you see the hyperechoic here within the toe cartilage, you might want to aspirate the fluid out for the crystal examination. Moreover, if you see the double contour sign here, which is a hyperechoic line above the toe cartilage, this might give you a picture of double contour sign, which is usually a gout deposition. Usually the gout crystal is bigger, so it cannot go into the toe cartilage and just only be deposit above the toe cartilage. If you see these two signs, you might want to aspirate the fluid out to check for the crystal. Moreover, if you see some of the irregularities here, this is the medial side and this is the medial side of different patients. If you see irregularities and thinning of the toe cartilage, you might want to think there's some sign of loss of cartilaginous loss, and those patients might have some lesion at the toe cartilage, and it might be a sign of early arthritis. And you might want to do some intervention on it also. And these signs are more sensitive than the X-ray. These signs will, sometimes the X-ray might not changing and you might not see anything at all in the X-ray. But when you see the sign here, you think of something in the cartilage. Okay. Next, you move, before we go up for the recess here, quadriceps tendons, and then we go for toe cartilage, and now we move up down to the patellar tendons. The patellar tendons, it starts from the inferior border of the patellas and go attached to the tibial tuberosities. You will see the fibrillar pattern nicely lined here like this. And you might see a little bit of the effusion here, which is infrapatellar bursa, and there's possible to have a fluid inside here. It's a physiologic fluid. Below the patellar tendon is the Hoffa fat pad. And you might check the bursa as well. First bursa, which is more common, is the prepatellar bursitis, which you might see in the housemaid knee. If your patient kneeling a lot, you might have an adventitious bursa up at the prepatellar bursa. The second bursa that can happen is the superficial infrapatellar bursa, which is here. Here. This is the superficial infrapatellar bursa, and this is the deep infrapatellar bursa. You might want to check a little bit. The superficial infrapatellar bursa is above the patellar tendons, but the deep infrapatellar bursa is below the patellar tendons. So these are three common bursa that can happen around the patellar tendons. And you want to check the qualities of the patellar tendons. Usually if you see a sign of hypoechoic or thickening of the patellar tendons, or the not lining beautifully of the patellar tendons, you might want to think it's a lesion of the patellar tendon, which usually is tendinosis. This patient have a tendinosis of patellar tendon with a sign of neovascularization. And it's also possible to have a crystal deposit in the tendon. Usually the patient will come with a very severe pain of the knee, and it's come and go. And when the crystal, there might be because when I follow up this patient, all the crystals are gone. And usually these crystals are associated with the uric acid in the level. So if the uric acid is less than 6, usually the crystals are gone. So these are also very useful tools when you're thinking of the crystal deposit tendon. The next pathology which can happen at the patellar tendon is apophysitis. There's two common apophysitis. The first one, which is very common, is the Osgood-Schlatter syndrome, and the second one is the Seiler-Larsen-Johansson syndrome. Basically, it's the same apophysitis, but it's happened in the different areas. The Seiler-Larsen-Johansson is happen at the inferior poles of the patellar tendons, and the Osgood-Schlatter is happening at the end of the patellar tendons at the tibial tuberosities. With these two, basically it's the same pathophysiology. It usually happens with the young athletes, and usually the tendons will be inflamed and painful, and you see cortical irregularities at the footprints of the patellar tendons here. If you have a patient who had patellar tendinosis which come from a chronic tendinopathy, usually I find a lot of jumpers, long jumps athletes have a thickening of patellar tendons. My usual intervention is the high volume injection, not in the patellar tendon, but below the patellar tendons. This is the pictures basically from the Achilles tendons paper, which explain about how the high volume injection helps the tendinosis of the tendons. This technique usually common use in two tendons. The first one is the patellar tendons, and the second one is the Achilles tendons. So the purposes of high volume injection is you inject the volume of at least 10 millimeters below the tendons. Try to stripping the tendons from the neo vessel, which the neo vessel usually causing the pain. So this is the picture, nice picture from one article that show how you inject the patellar tendon. Usually I also, with this technique, I go transverse and you go hit your needles just below the patellar tendon and above the Hoffa pad. This is a non-painful technique, and it go very well with the athletes who had to still practicing and cannot stop practicing. So we move from the anterior view to the medial view. The first thing you want to see in the medial view is the MCL, medial collateral ligaments. The second one is the meniscus, and the third one is the pes anserinus insertion. Medial collateral ligaments so basically the patient who has knee problem, we have two categories. The first one is the athletes who are very healthy and have some accident with it. The second population is the degenerative osteoarthritis patient. These MCL usually have pathology in both group of patients. So the first group of patients, which is the athletes, they can have an MCL injury, usually common in the femur portion of the MCL, and femur portion MCL usually conservative treatment only. So what you want to see in the MCL is the first part is the superficial part of the MCL here with the the arrow here. And the deep part of the MCL is here as well, the arrowhead here. And there's the meniscofemoral and meniscofibrial part of the MCL, which connect to the capsule and the meniscus. In the sports people who has a medial knee pain, you would like to check the MCL injury. The MCL injury might appear as the discontinuities of the fibular patterns or swelling of the fibular patterns or hypoechoic area in the MCL. Like this patient, you see there's a hypoechoic area which correlate with the pain of the patient also. Okay. And furthermore, you might see the calcified MCL here, which correlate with the X-rays. The calcified MCL usually correlate with the old injury of MCL and old MCL tear. You might see the MCL bursitis, which usually you can see it's contained in the upper part of the MCL bursa. And this, when you see the effusion like this, you want to check whether it's connected to the medial recess of the knee joint or not. But this one is not connected, and it's very painful. After I aspirate it, it's a lot better. Okay, and next we go to pes anserine, which is above the MCL tendon here. Usually, personally, I didn't find a lot of pes anserinous bursitis. Usually, it's MCL bursitis. If there's a meniscus injury, you might see a fusion along here and be around here at the MCL and next to the pes anserine, and you might think it's a pes anserine, but usually it's the meniscus injury and MCL lesion. Okay, next is a medial meniscus. The normal medial meniscus will appear as hypoechoic, triangular appearance. You can see a lot of abnormal finding, and actually it's very sensitive if it's a horizontal, radial, and flap or complex tear of a meniscus. However, if it's a vertical or bucket handle tear, it's not that sensitive. You will think of the meniscus tear when you see irregular edge or hypoechoic or anechoic area within the meniscus or some extrusion as well. You might see some indirect sign of meniscus injury, which is, for example, parameniscus cyst, or you can even see meniscus cyst. This is a nice photo from my colleagues, a parameniscus cyst. You will see effusion next to the meniscus, and this is indirect sign for meniscus tear. You can aspirate it because it's also painful and it's usually help. Next one is usually happen in osteoarthritis patient or degenerative patient. It's a meniscus extrusion with neovascularization here, PDI positive. With the meniscus extrusion, usually it's a very painful. Your patient with osteoarthritis may come with cannot bear the weight on that limb. It's very, very painful, and it's happen with when it's the meniscus tear and it's extrude up and it's compressed with the MCL, and you're gonna see the MCL bursa swelling, and usually you will see parameniscus recess as well. Usually the clinical finding is here. You will see increased distance between the tibial bones and the most extruded meniscus. You might see the swollen of the MCL bursa and the thickening, and might see the parameniscal recess distension as well, like this patient. This is the osteophyte. You might see it or you might not see it. Okay, and how to diagnose the meniscus extrusion? Usually there's a lot of criteria on it. The most sensitive one maybe is the 3 millimeters extruded from the tibial margin here. The meniscus extrusion is associated with meniscus posterior root tear, complex tear, or degenerative meniscus. The most common that I saw is the degenerative meniscus tear. And it shows an excellent diagnosis performance here. Okay, so this is the technique I learned last year from the first Asian meeting conference, the MCL bursa injection. There's a nice paper done by the Japanese colleagues here, and it shows 76% success rate. Usually with the MCL bursa injection, they choose the patient who has a medial knee pain with a meniscus extrusion. In the paper, it's a KL around 1 or 2, and they choose to inject the steroids in the MCL bursa, like this. Usually, this is my patient. I used 40 milligrams of triamcinolone with xylocaine, inject at the MCL bursa. Usually after injection, the patient will say they have a new knee. It's very, very successful injection and very painless injection. If you see athletes with the MCL injection, this is my rugby player athlete. He has a MCL tear, grade 2, and the orthopedic surgeon said this is a conservative treatment. He's very, very, very nervous about it because he had to stop from practicing. What did I do with him is I inject the prolotherapy inside the MCL lesion, and I follow up with the PRP injection. Almost the last one is the lateral view. The three structure that is more common in the lateral view is iliotibial band, ICL, and the lateral meniscus. So basically, to scan it, you have to know the origin and insertion. The iliotibial band will insert at the Gertie tubercle, and the LCL will intact at the fibula head. Iliotibial band, I believe all of you have seen the patient with iliotibial band syndrome. The point of it might be non-relevant because some of the doctors doesn't believe that iliotibial band syndrome really exists. This is a nice picture from the research. Show that there's a bursitis between iliotibial band and the lateral femoral condyles. And some of the research said that you can see the clicking of the iliotibial band friction syndrome as well. The next one is the lateral collateral ligaments. LCL is a lot less common injury, especially in degenerative patient and also in the athlete's patient. But it's also happen if there's a direct contact at the lateral knee. So you want to check from the femoral, from the fibula head to the femur, like this, which I'll show you later. You might want to check the same criteria as the MCL. It might be hypoechoic, thickening, or discontinuities of the fibula pattern here. And you see a lateral meniscus here as well. The lateral meniscus is also the same character as the medial meniscus. Hyperechoic triangular appearance. The lateral meniscus, if you see a pathology here in the degenerative patient, it usually means that patient has a more severe than when you see the patient who has a medial knee meniscus extrusion. The extrusion can also happen here as well, but it's associated with more severe patient. And in the athletes, you can also see horizontal tear and different type of tear as well in the lateral meniscus. The last one is the posterior view. The only one that I'm gonna talk about is the Baker cyst. Baker cyst is usually connected with a joint effusion, and if the patient comes with Baker cyst, you have to check the joint effusion as well. That's why before you scan the knee, I recommend you to do the anterior view first. So the characteristics of Baker cyst, you have to have the stalk. You have the nice Baker cyst with between the semimembranous and medial head of gastrocnemius, and you have to find the stalk as well here. Because not all of the popliteus mass is the Baker cyst. You don't want to inject into some lymphangioma or something, so before you inject it, you have to put the power Doppler on and you have to find the stalk. This is the technique I learned from Dr. Jacobson from the conference. Is the stalk fenestration. The goal is to try to fribus around the neck of the Baker cyst to try to close the Baker cyst. Some of the technique are not the stalk fenestration. I heard about some technique that they do a cyst, like a fenestration of the cyst wall as well, but personally I do this technique. So for conclusion, you will see that with ultrasound, you can see a lot of pathology and a lot of structures. Anterior view, medial view, lateral view, and posterior view. And there's a lot more structure that I didn't mention in this topic. And ultrasound shows high sensitivity and is easily accessible. So I recommend you all to, when you see a knee patient, don't forget to bring your ultrasound machine. This is my workshop, which are only for Thai colleagues. Actually, you have like 20 Thai colleagues here. So if you're interested, please stay tuned and register for this workshop. And arigato, Toru-sensei. This is the last ultrasound meeting. the picture from the last year, and I hope to see you again next year. Here with the MCL. Okay, here. This is the MCL. This is the MCL here. As I mentioned, there's some say 3 layers and some say 2. Usually it's 3 layers. It's superficial here, up here, and this is the deep MCL, and this is the meniscofemoral part and the meniscofemoral tibial part here. And then you want to go down and you trace the MCL here, here, and up above the MCL is the test. You can check the dynamic also, but this is a very nice MCL. And with the lateral side, a lot of technique come from, so they recommend to palpate the fibular head, and you put the probe on the fibular head first, here. And then you heading to the condyle. I'm looking for the LCL, okay, here. You see the LCL. You have to toggle the probe a little bit. Some of the speakers said that you can toggle it anterior and posterior just to see the nice fibular pattern here. Some say it's pencil-like, I don't know, here. And this is the LCL here. And up here is a popliteal fossa, and you can see the meniscus as well. Here, upper meniscus.
Here.
Sorry. Here, lateral meniscus. And for ITE, you moving to the vertebral, and you see a nice ITE band. Okay? Good.
The knee. So especially in the medial meniscus, the X region. He's got lots of award from the Japanese society and the international society. So I asked him to have the advanced treatment option for the knee joint. Are you ready?
Yeah. Okay. Good morning, everyone. Thank you and Paul for giving me the opportunity of this presentation. Okay. First, let me introduce myself. I'm 38, not so young. So this is my family. So I love them. However, I have 3 lovers. Of course, my wife has given her content. That's okay. That's okay. Okay. First is I love new surgery, and second ultrasound, and playing sports. I play baseball every weekend, and I learn. In this morning, I learned with Dr. Onishi and my boss. Okay, let's move on. Okay, today I'll talk about ultrasound guided intervention for knee pain. So first, I have a question for you all. Do you know the meaning of the Japanese word itai or itami? Pain. Pain? Oh, why do you know? It means pain or painful. Yeah. Today, I show you some videos in which patients speak Japanese. Maybe you can't understand. However, as long as you know this Japanese word itai, yeah, you can understand how patients feel. Okay? Okay, today's topic is knee pain. Knee pain is something we perceive through the nerve. So today we will focus on the nerve around the knee. There are many nerves around the knee, so any of them can be source of the pain. Therefore, these nerves became important target in the treatment strategies. Today, due to the time limitation, we focus on the 3 commonly encountered nerves in clinical practice. The first, common pyramidal nerve. Second, medial genicular nerve. The third, infraparietal branch of surface nerve. The visualization difficulty increased in this order. Okay, let's start with the common pyramidal nerve. This is anatomical review of the common pyramidal nerve. This nerve branches from the sciatic nerve and run between the biceps femoris and the lateral head of the gastrocnemius, like this, to the femoral head. In ultrasound, before explaining the ultrasound image, all the image in the next few pages show the medial and proximal side on the left, and the lateral and distal side on the right side. Okay. In ultrasound anatomy of CPN, the key landmarks are sciatic nerve, short head of the biceps femoris, lateral head of the gastrocnemius, and femoral head. Okay, and show this video. This is the sciatic nerve. This is the short head of biceps. This is the lateral head of the gastrocnemius. This is the femoral head. By following this structure, you always be able to visualize the common peroneal nerve. Here, this is common peroneal nerve. Yeah, this is a cuteness nerve. Okay, indication for therapeutic intervention to the common peroneal nerve is limitation of knee extension and tenderness or pain during the knee extension at the posterolateral knee.
左膝ね、
left knee.
伸ばすと痛いね。
痛い。
内側は痛くない。
Yeah, no pain on the medial side, no pain on the central.
これね。
Yeah, pain on the posterolateral side. Okay, in clinical practice, prior to the intervention, ultrasound guided observation and palpation should be performed. In this case, this is common peroneal nerve. This is femur. Okay, you can observe. Okay, I palpate. Okay, the common peroneal nerve lies directly under the point of the tenderness. Okay, in this case, pain was suspected to be caused by sliding disorder of the common peroneal nerve, and I performed hydrorelease for common peroneal nerve. Okay, a key to successful injection is circumferential hydrorelease for nerve using implant method. I release the deep layer of the nerve, and next I release the superficial layer of the nerve. Okay. This is needle tip, like this. Okay, next, let's move on to the medial genicular nerve, the main topic of my presentation. As you know, medial genicular nerve provides sensory innervation to the pestic ostium and joint capsule, making it a therapeutic target in the patient with moderate to severe knee OA. Anatomically, it shows variation. For example, SMGN, superior medial genicular nerve, originates from the femoral, saphenous, and tibial nerve, and typically at least 3 nerves are presented. Okay, let's start with SMGN. So this is a dissection of the left cadaveric knee. We can see the 2 types of SMGN in this picture. Yeah? The one branch originates from the saphenous nerve right here. It's run to the anterior to the abductor muscle tendon right here. The another branch goes for behind. It's maybe from tibial nerve right here. Okay, the blood vessel accompanies the nerve. Both branches are important therapeutic target. Okay, to observe SMGN from a saphenous nerve with ultrasound, the probe is placed anterior to adductor tubercle in the long axis view, and SMGA and SMGN are observed in the soft tissue on the distal end of the vastus medialis. This beautiful triangle shape is a landmark. Actually, we cannot detect SMGN, but SMGN accompanies SMGA. Okay, I'll demonstrate later. Ultrasound scanning begins the probe placed longitudinally using adductor tubercle as a landmark. This is adductor tubercle. I place here and slide anterior. You can see the vastus medialis triangle shape. and switch to the Doppler mode. You can see SMGA here. And to visualize the SMGA branches from tibial nerve, okay, slide the probe slightly proximal from the triangle shape of the vastus medialis, slightly proximal, and SMGA running, SMGA running from the behind, identified between the vastus medialis and femora, or more. Vastus medialis and femora. This is the SMGN from behind, maybe from tibial nerve. Okay, the indication of SMGN injection is moderate to severe medial knee OA patient. Patients showing the positive blood flow signal in the femur on ultrasound or bone marrow region on MRI, often patients with significant pain are good indicator for injection. For such case, I perform either nerve block or radiofrequency device ablation. In all cases, a nerve block is performed as the initial step. This is a case, 57 years old man. He has severe knee pain during work. You can see that the walking speed is really slow. In ultrasound, this is the SMGN. So I performed injection with the short axis view. So I usually check the short axis view of SMGA. So this is the injection procedure video. This position I performed the injection. The injection is performed under careful observation to avoid inadvertent intra-articular injection. The injection is a rapid onset of action. Pain relief can be immediately. Yeah. However, the key factor is the duration of the effect. Depending on it, we decide the subsequent treatment plan as indicated. If the injection targeting the SMGN from saphenous nerve is not sufficiently effective, the second injection is performed targeting the SMGN from behind tibial nerve. This is SMGN from tibial nerve. I inject here. But sometimes I perform 2 injections for a patient. Okay, and next we look at the IMGN, inferior medial genicular nerve. About anatomy of IMGN, IMGN is branched from the tibial nerve and run anterior around the tibia, accompanying the inferior medial genicular artery, and finally enter the space of superficial MCL and tibia, this space, that's shown as the red space. To observe the IMGN with ultrasound, the probe is placed anterior to distal the tibial epicondyle and joint line here, and IMGN are observed in the soft tissue here between the superficial MCL and tibial slope. I show IMGN drawing procedure in subsequence. First, set the probe on the superficial MCL in the long axis view. Second, slide the probe until the distal direction. And identification IMGA and the space between superficial and MCL and tibial. Sometimes we cannot detect IMGN directly. I perform inject the space between the superficial MCL and tibia, this yellow space. The indication of IMGN injection is a moderate severe medial knee OA, as with SMGN. Ultrasound and MRI findings are used as reference. Okay, this is a video of IMGN injection using in-plane method. This is the needle tip. This is needle. I inject 1% lidocaine and triamcinolone to the space between superficial MCL and tibia. But we often encounter cases in which the nerve block is really effective, but the effect quickly wear off. In such case, the next therapeutic option is RF ablation. As for RF ablation, Dr. Katayama explained it yesterday. In Japan, the RF ablation system currently covered by insurance is COOLIEF, named COOLIEF. COOLIEF is a cooled RF ablation system using the treatment chronic pain, especially knee osteoarthritis. Okay, let me show one example where we use COOLIEF. This is a 50-year-old male with severe knee OA patient. He strongly preferred not to undergo surgery. So we consider COOLIEF as a treatment option. The patient had pain not only medial side, but also lateral side. Based on that, we target these three nerves, SLGN, SMGN, IMGN targeted. Here I explain the procedure for targeting IMGN. Okay. First, I administer ultrasound guided local anesthesia using short axis view, and next guided the tip of the COOLIEF probe position next to the IMGN. The ablation performed 60 degrees Celsius for 2 minutes and 30 seconds. One more. Local anesthesia first, and the guide and tip next to the SMGA, and ablate 60 degrees and 2 minutes and 30 seconds. The same procedure was performed on the SLGN and SMGN as well. The total procedure time was about 30 minutes. This as the patient woke just after the treatment. You may not be able to see his face because of mask. He usually has a little bit scary face, but at the time he smiled. Yeah, I'm so relieved. Okay, lastly, we targeted the infrapatellar branch of saphenous nerve. Now, regarding the anatomy of the infrapatellar branch of saphenous nerve, in most cases, the branch originates from the saphenous nerve, like it, and penetrates the sartorius muscle at the distal end of the abdominal canal. This is the abdominal canal. They penetrate the sartorius muscle. And through the and travel through the subcutaneous tissue distal the patella. However, it has been reported that origin and cause of the branch can vary significantly among individuals. According to the multiple study, the infrapatellar branch of saphenous nerve shows considerable anatomical variations. So, this variability is one of the main reasons why ultrasound identification of this nerve is so challenging. So, how can we reliably visualize this nerve with ultrasound? The answer is in this red circle. That despite the variation in its course, the nerve allows pass through this area, so making it a reliable landmark for ultrasound identification. On ultrasound, we can identify this anatomical region about 5 centimeters approximately from the joint line. At this level, this is the fat space. This is fat space between the sartorius muscle and bursas medialis muscle. This space serves a reliable landmark as an inferior branch of saphenous nerve, always run within it. From this position, if we follow the nerve distally like this, we can see the this nerve. You can see this nerve. Okay, can you see? Yeah, you can see the infrapatellar branch of saphenous nerve. Now, of course, by moving the probe to the proximally, you can visualize the nerve into the penetrates through the sartorius muscle. This is nerve. This nerve can penetrate the sartorius muscle here. Okay, but however, keep in mind that anatomical variation do exist. Okay. Here is a representative case of infrapatellar branch of saphenous nerve entrapment syndrome. This is a 45-year-old female who presented 3 months after ACL reconstruction. She complained of severe medial portal pain with NRS of 9. She said 痛い、超痛い。Ultrasound examination revealed that infrapatellar branch here, and it is scar tissue, and trapped post-operative scar tissue at the portal site. Like that. In this case, I performed ultrasound guided hydrolysis using saline. This is nerve. I use the autoplane method, like this. Okay, immediately after the injection, the pain relieved. Okay, and she remained pain-free even 6 months later. 6 months later, yeah. Until recently, there were few effective therapeutic options for such iatrogenic nerve injury. But now we are able to visualize the nerve with ultrasound. So we have new therapeutic possibility, including precious injection and alpha-ablation. Okay, here's a summary. Nerve can be key target in the treatment of knee pain. For posterolateral pain and extension limitation, consider the common peroneal nerve, and for bone and periosteum pain in knee OA patients. The genicular nerve are often effective target. And the post-operative anterior knee pain or numbness, so we should check the infrapatellar branch of saphenous nerve. Okay, please consider these nerves are part of your treatment strategies. Okay, thank you for your attention.
Yeah.
Okay.
Okay.
Okay, is there any audience who can do the PRP injection here? PRP injection? Okay, the over the half of the participants are doing the PRP injection. How about the PRP injection for ACL tear? Wow. About, oh yes, over 12 or 15. How about the intraosseous injection? Wow, yeah, relatively few people. But yes, that means the most of the audience today are very interested in the new procedure using the PRP. Yes. Okay?
Okay.
Okay, thank you.
Thank you for invitation, Dr. Mondani. I will do presentation, terrible English. I'm me, graduated from Toho University and now Department of Orthopedic Surgery, Juntendo University. And specialty is here, I think, at least. I work at Juntendo University now, but timely, new workplace from July 1, Juntendo Tokyo Kyoto Geriatric Medical Center. Haneda Airport, Asakusa, Tokyo Disneyland, it's center of Tokyo. Yeah. Outside clinic, I treat patients once a week. My family clinic had a medical clinic. My father, Japanese say, Oyaji. The clinic is located in Gotokuji. And Gotokuji is a historic temple in Tokyo. Icon is Maneki Neko. It's mean lucky cat. Train station, lucky cat. Everybody lucky cat. And recently, many foreign tourists have been visiting. What is PRP? Blood collection, centrifugation, isolation, injection. Concentrated platelet have growth factors, anti-inflammatory cytokines. It's powerful healing and anti-inflammatory effects. It's a power material. How do you imagine PRP therapy, sports medicine, or NEOA? In addition, PRP's true value depends on how it's used. great potential with creative application. In Europe, effective for symptom relief for NEO-A. But intraarticular injection alone has some effect, but NEO-A is diverse therapeutic targets, ossified cartilage, bone marrow region, meniscal region. Focusing treatment boosts PRP's potential and value. Major risk factor for NEO-A, medial meniscus extrusion, increased load on cartilage, major cause of joint space narrowing, early intervention target. Progression of MME leads to intrameniscal degeneration progress, and progressive degeneration induces meniscal tear. What's happening around the extruded meniscus? Doppler near MME and tenderness point near from MME. Anteromedial pain, most common MME site. And I investigate MME and synovitis and pain, ultrasound analysis. Synovitis grade correlate with MME width and pain grade. Untreated synovitis lead to synovitis is a risk factor for OA progression. Why? Synovitis induces angiogenesis and synovial thickening. Synovial thickening and synovial meniscus adhesion leads to joint fibrosis. And angiogenesis and joint fibrosis induce pain and decreased mobility. And synovial thickening lead to synovial chondrophyte, finally osteophyte. I investigate osteophyte and MME. MME correlate most strongly with medial tibial osteophyte. We hypothesis medial tibial osteophyte compress coronary ligament. MME increase. Therefore, PRP targeting medial meniscus and surround structures. Synovitis thickening suppression or degenerative meniscal healing effect. Osteophyte, MME, and meniscal tear, hoping for suppression. This is perimeniscal PRP technique. 35-year-old female professional wrestler. Check tenderness site, check for synovitis, and inject between MCL and meniscus. And angle change. Versus tendon, meniscus. And medial meniscus tear in early OA, degenerative tear is high in frequency but low in risk. MMPRT, low in frequency but high in risk. My dream is to repair degenerative meniscus. It's one RCT, PRP versus no PRP in ultrasound guided needling for degenerative meniscus. Meniscus repair success rate, PRP group is 52, but no PRP group 33. One case series, PRP injection into degenerative meniscus healed in 4 of 10 cases. Intrameniscal PRP technique. Since the procedure can be painful, I add a small amount of local anesthetic. Once a needle is in the meniscus, switch to PRP and inject. This is needle. I repair the case after 10 weeks, healing, success or lucky. I don't know. Medial meniscus posterior tear, MPRT, risk of progression of MME. It's semi-membranous tendon related to posterior medial knee pain and MMPRT. Elastography in patients with NEO-A hamstrings are stiffer and correlate with knee pain. Is reducing hamstring tension also important? Intrameniscal PRP and hamstring release technique at injury, MME 2.6 millimeter, local anesthetic with 5% dextrose, approximately 10 milliliter, long needle. Dissection between the O. Dissection between the meniscus and hamstring tendon. And advance a long needle into the meniscus. Switch PRP. Half inject into the meniscus and then gradually withdraw with continued injection. Finally injected into the peripheral area. Six months healing and no advanced MME. Lucky. Intra-articular PRP for knee OA. My selection of injection methods, pain and lesions are localized. Extra-articular injection, diffuse tenderness and or effusion, intra-articular injection. My ideal ichigeki, a Japanese karate term meaning a one-hit knockout. When I do PRP, I aim for one shot, one relief. How can I achieve ichigeki? Patellofemoral joint pressure may affect PRP injection outcome. Key issues in the patellofemoral joint: ELPS, excessive lateral pressure syndrome, lateral tilt of the patella, and tight lateral retinaculum, and MAS, medial abrasion syndrome. Fibrotic second medial plica causes friction with the femoral condyle cartilage. This is a plica and arthroscopy plica and loss of cartilage, normal area. Observed in 88% of knee OA case. Extra or peri-articular injection plus intra-articular PRP, lucky. Treatment for ELPS, ULR, ultrasound guided lateral release. In this case, patellar tilt 23 and 3 milliliter of lidocaine and 7 milliliter dextrose. 3, 2, 1. Needle into the lateral retinaculum, wide dissection of superficial and deep layers, widely. The deep area, release, release, release. After the release, I mobilize the area and say, be good now. This case, patellar tilt improvement, lucky. My favorite techniques for MAS, medial ablation syndrome, ultrasound guided medial release, similarly lateral release, medial pelvic release, and meniscus, surround meniscus release. My Ichigeki technique, extra-articular head release and intra-articular PRP. It's medial pelvic and pelvic synovial release. And angular adjustment for release around the medial meniscus. Release. And PRP injection follows extra-articular treatment. Intra-articular injection.
入れたままいきます。
It's my Ichigeki technique. Okay. Last one, PRP for anterior cruciate ligament ACL. PRP promotes healing of injured ACL, PDGF, IGF-1, stimulates mesenchymal cells, and fibroblasts. Case series, predatory therapy for ACL professional soccer players, 81% players return to play injury level in 6 weeks. And RCT PRP treatment after ACL reconstruction, ACLR, 6 months PRP group showed better outcome, diagonal score, ligament maturation, but 12 months, no difference. Could support faster return to play. Direct injection into the ACL convex flex knee position, 22 gauge long needle. This MRI and echo. Infravater fat pad and femur tibial. This is ACL. Movie. This is ACL. And injection. Using long needle. Case combined with ACLR, 36 years old competitor in Brazilian Jiu-Jitsu, chronic ACL injury with spaghetti handle tear of the medial meniscus. I performed ACLR plus medial meniscus repair, fluid bearing next day, PRP 3 times. And 3.5 months graft maturation, meniscal healing, who alone, recovery, pivot shift, okay. Limb symmetry, okay. 4 months return to full training. And 6 months international tournament winner. 1 year, no complaints and no re-rupture. No operative case, 34-year-old elite MMA fighter. Injury day 25, first visit is pivot shift word 3. PRP weekly 5 times. Day 51, jogging and kick training. 71, return to full training. And 103, match day. This golden hair fighter. He strikes the knee. Very good. 4 months repaired, and now no complaints and no re-rupture. 10 cases of conservative treatment, memory assessment, 7 cases healed with low signal, very good, excellent. 2 cases healed with high signal, good. 1 case healed with thinning, 0 case poor. But 1 case relapture. All patients return sports in 4.6 months. Here comes our unreleased data. 40 case retrospective study. Success rate is 82%. Failure rate 17%. Success or failure, it depends on age. 30 years old over, very good. Tear site, femoral tear, good. Severity, partial tear, very good. Higher age is associated with a higher success rate. Poor outcomes in teenagers. Short-lived success rate 55%. 1 year success rate 22. Joint trachicity, skeletal structure, use specific tear pattern. We'll be exploring this in future studies. That's all. Until the day I can achieve ichigeki for every patient, I will continue to train and grow for the rest of my life. It's shugyo. Thank you. Thanks a lot. I speak English just enough to start.
It begins with a detailed history and a focused physical exam, with advanced imaging supporting the precise identification of the pain source. Ultrasound is particularly valuable as both a diagnostic and interventional tool, allowing us to bridge clinical findings with imaging in real time. When evaluating shoulder pain, it is important to consider several key elements in the patient's history. Age is a major factor, as certain conditions such as degenerative cuff tears and arthritis of the glenohumeral and acromioclavicular joint are common in older adults. Sporting activities, particularly those involving overhead motions or heavy lifting, can predispose patients to injuries like biceps tendinitis or labral tears. Occupation is also relevant, as repetitive overhead work may contribute to impingement symptoms. A history of trauma, even minor, can be a trigger for conditions like adhesive capsulitis. Understanding the chronicity of symptoms helps differentiate between acute and long-standing issues. Finally, always consider associated medical conditions such as cervical radiculopathy, which can refer pain to the shoulder and mimic intrinsic shoulder pathology. So examination starts with inspection and palpation. Observe for atrophy or asymmetry. Palpate bony landmarks like bicipital groove and AC joint. Assess active and passive range of motion in both standing and supine positions. And most importantly, use special tests judiciously to narrow down your differentials. Let's go through the rotator cuff tests. For subscapularis, use lift off, belly press, and bear hug test. For supraspinatus, perform supraspinatus strength testing, Jobs and drop arm. For infraspinatus, assess resisted external rotation test and external rotation lag sign. For teres minor, check for horn blower sign. For impingement, Neers, Hawkins, Kennedy, Yoakum, and painful arc are key. The accuracy of these tests increases when used in clusters rather than in isolation. For anterior shoulder pain, perform the coracoid impingement test. Include tests for biceps tendon pathology like Speeds and Ergasons. For the AC joint, crossbody adduction works very well. For labral pathology, O'Brien's and the dynamic labral shear test are helpful. For anterior instability, remember the load and shift, apprehension, and relegation test. So let me share my systemic approach to performing special tests in the clinic. So I'd like to invite Dr. John, my colleague, to the front for a quick demonstration. So after inspection and palpation, so you instruct the patient to face you, then start with supraspinatus strength testing, okay, and you resist. Okay, if there's any pain, then you might consider for a supraspinatus problem. Jobs like this, thumbs down. So speeds for biceps pathology. Then O'Brien's 15 degrees inside, internal rotation. Okay. If there's pain on this in this part, but on this position, but no pain on supination, then you could have a superior labrum problem. Then after, you instruct the patient to do a lift off side like this and push the back. Then belly press. Ooh. Okay. Then external rotation. Strength. 1, 2, 3, go. Okay. Check for lag sides. Then go again. Yokum. You instruct the patient to lift the elbow up. If there's pain in this test, then you can consider a subacromial bursitis. Then while in this position, you can do a cross abduction test to check for AC joint problems. Then painful arc, you instruct the patient to raise his hand on the side, and if there's pain on the 60 to 120 degree, then you can maybe check for a subacromial bursitis. You do Neers and Hawkins Kennedy. Okay, thank you. So that's my quick way of assessing a patient in the clinic. Thank you, Dr. John. So recognizing clinical patterns can help narrow down the differential diagnosis quickly. For example, frozen shoulder often presents with global stiffness, particularly limited forward flexion and external rotation, both active and passive. If the patient maintains full range of motion but complains of pain with overhead activity, think impingement syndrome. Tenderness over the bicipital groove, especially with a positive Speeds or Yergason's test, points towards biceps tendinitis. A positive Jobs or drop arm test combined with weakness suggests a rotator cuff tear. Surgeon-performed ultrasound offers a real-time decision making. We correlate anatomy directly with the clinical complaint, avoiding unnecessary imaging delays. It's cost-effective and improves outcomes by facilitating faster, targeted interventions, especially for injections and dynamic assessments. Now that you're ready to scan, it's important to grasp the scanning planes. Longitudinal long axis scans parallel to the structure, while transverse short axis scans perpendicular to it. For example, when the probe is parallel to the biceps tendon in the long axis, you see its length. In the short axis, the probe is perpendicular, showing a cross-section of the tendon. If you're still confused with scanning planes, this illustration might help clarify things. So this is a longitudinal axis, and this is a short transverse axis. When holding the transducer, hold it firmly while bracing the pinky finger or ulnar side of the hand on the patient for added control. This provides stability for smooth scanning with precise movements. So here are ultrasound terms. Echogenicity describes how a structure reflects sound waves during ultrasound. The four main terms are anechoic, meaning no echoes, appearing very dark, which is seen in blood vessels or cysts. Isoechoic, same echogenicity as surrounding tissue, used for normal structures. Hypoechoic, less reflective, appearing darker, seen in tendinosis or tears. and hyperechoic, more reflective, appearing brighter, seen in bone and calcifications. With that in mind, here's what we typically see on the ultrasound monitor when scanning the shoulder region. Ultrasound scanning of the shoulder should follow a systemic, region-based approach to ensure no pathology is missed. Here are the key structures visualized based on probe positioning. Start with the anterior aspect to view the biceps tendon, subscapularis, and subcoracoid bursa. Have the patient seated with their hand on the thigh. This slight internal rotation of around 15 degrees helps bring the biceps tendon into optimal view. Place the probe anteriorly on a transverse plane to examine the long head of the biceps tendon in short axis. The biceps tendon passes through the bicipital groove, which is formed between the greater tuberosity laterally and lesser tuberosity medially, and has an hyperechoic elliptical shape. There is a transverse ligament between the two tuberosities. Centering over the biceps tendon, move the probe superiorly along the length of the tendon to inspect the status of the tendon. Tendons are hypoechoic, but improper beam angle can make them appear darker, mimicking a tear. This is called anisotrophy. Rotate the probe 90 degrees over the biceps tendon to obtain a long axis view and assess its length. Hypoechoic shadows surrounding the long head of the biceps tendon may suggest effusion and tendinitis. The picture showing flattened and widened subluxated biceps tendon blanketing the lesser tuberosity. To evaluate the subscapularis, place the probe in the transverse plane for a long axis view and externally rotate the shoulder to tension the tendon for better visualization. Look for hyperechoic tendon inserting on the lesser tuberosity. Place the probe 90 degrees over the lesser tuberosity and assess the subscapularis tendon in short axis. In this view, it is common to see interfaces between the several tendon bundles. Ultrasound images of the subscapularis tendon in long axis and short axis show absence of the tendon at the lesser tuberosity and proximal retraction. To assess the subcoracoid bursa, apply gentle probe pressure, as excessive force can compress fluid and obscure signs of bursitis. At the superolateral aspect, the supraspinatus and infraspinatus tendons, along with the subacromial bursa, are visualized. Use the modified CRAS position, hand on hip, elbow directed posteriorly, to internal rotate the humerus and bring the greater tuberosity anteriorly. Place the probe sagittally for a long axis view of the supraspinatus, then rotate 90 degrees for a short axis view. Note the supraspinatus attaching to the greater tuberosity. From anterior, slide the probe posteriorly to visualize the supraspinatus and infraspinatus insertions. The supraspinatus tendon attaches to the superior facet and the infraspinatus to the middle facet of the greater tuberosity, distinguishable by their different inclinations. The transducer is placed transverse for a short axis image of the supraspinatus. So here, ultrasound images of supraspinatus in long axis and short axis view shows anechoic and isoechoic heterogeneous disruption of the tendon fibers. Hyperechoic signals seen within the rotator cuff tendon. This is suggestive of calcific tendinitis. To evaluate the subacromial bursa, place the probe between the greater tuberosity and acromion. Understanding the sonoanatomy is key. The supraspinatus inserts on the greater tuberosity, and the bursa lies just above it. Superficial structures include prebursal fat, and the deltoid, and subcutaneous fat. Next, examine the posterior aspect in neutral sitting position. This gives a good view of the infraspinatus and teres minor tendons. Move to the superomedial aspect to assess the acromioclavicular joint with the patient's hand resting on the thigh. This reveals the articulation between the acromion and the clavicle. Finally, for the axillary aspect, ask the patient to place their hand behind the head or on the occiput. This position helps assess the anterior inferior glenohumeral ligament and the labrum. With a working diagnosis established through history, physical exam, and imaging, you can now develop a treatment plan, ultrasound-guided injections being one very effective option. So ultrasound-guided injections are now well established in the literature as more accurate and effective than landmark-guided techniques. Injections can be in plane or out of plane. In plane means the needle is inserted parallel to the transducer, and the entire needle shaft and tip is visualized along its course. Out of plane means the needle is inserted perpendicular to the transducer. Injection through the glenohumeral joint can either be in plane or out of plane. For in plane, position the patient in lateral recumbency, placing the probe posteriorly in between the glenoid and the humeral head. The needle is directed from the lateral side of the probe, aiming the tip between the humeral head and the glenoid labrum. It can also be done out of plane, my preferred method, though it's more challenging as the needle shaft isn't visible. For the subacromial bursa, position the patient in the CRAS position and use an in-plane approach. Observe the hypoechoic injectate feeling the bursa. For the subcoracoid bursa, position the patient supine with the shoulder in external rotation and use an in-plane approach. AC joint injections can be in plane or out of plane. For in plane, position the patient seated with the hand on the thigh, place the probe above the AC joint, and advance the needle medially towards the joint space. This is the out of plane approach, my preferred method, as it offers a better angle and allows deeper needle placement in the joint. Biceps tendon sheath injections can be performed in plane or out of plane. Position the patient supine with slight external rotation. Insert the needle laterally, aiming the tip just above the tendon. So this is my last slide. So in closing, ultrasound technology continues to evolve with high resolution probes and AI-based interpretation. But clinical skills remain paramount. Know your anatomy, master your scan technique, and correlate everything with the physical exam. Thank you. 15-degree internal rotation, and you can clearly see the biceps in the bicipital groove. Okay. So here. So this is the lesser tuberosity.
This is the biceps tendon here. So you can trace it starting from distally going superiorly. There. And to check for subscapularis, instruct the patient to external rotate, like this. So here, and move your probe medially in the medial. So again, this is your subscapularis. This is the lesser tuberosity.
Janos, this model has the bursitis on the subscapularis tendon?
Yeah. you have a shoulder pain? No. But he doesn't complain of anything. So. Yeah. So this is a bit, this is a fusion, so that's a subscapularis tendon. So it's very important to external rotate the shoulder, because if you look at, if you check on internal rotation, you won't be able to see the whole length of the fiber of the subscapularis. But if you do external rotation, you can clearly see it here. Okay, so you can assess for tears, partial tears, complete tears. Also for the biceps tendon, you can see effusion here. Okay. So after checking the anterior aspect, you can proceed with the superolateral aspect by instructing the patient to do the crash position. Can you put your hand in the back? That. Okay. And do it again. Okay, good. So remember what the facets I mentioned to you about. So here, this is the long axis view of the supraspinatus tendon, and if you can see the facet, it's the inclination is very high. So you're confident that this is the supraspinatus tendon, and if you go posteriorly, the inclination of the facet decreases. So you see the infraspinatus all the way. Also, you can check it via short axis also. Here. Okay. Then you check. Then you're ready to move to the posterior side. And have gel.
Should be.
So the placement of the hand is very important. So just put it in your thigh. And also, if you have trouble looking for the joint, you can ask the patient to move his shoulder. So you know that this is the glenoid, and this is the humerus. And this is the infra or teres minor, below. Okay. See? So if you want to do injection, you can do this. You can do it in this position, in plane approach, or out of plane. After, you go to the superomedial. Look for the AC joint. So here. So usually if there's an AC joint problem, you'll see a fusion and hypertrophy of the ligament. Okay, and it's if you do AC joint injection, it would be better to use a hockey stick so that you can have a smaller probe, and it's easier. And lastly, to check for scenario. Just like this. Can I have more? Thank you. Thank you. Can you go deeper? So that's the glenoid, and this is the humerus here. But of course, for instability, it would be best if you get an MRI. Okay.
Good morning, everyone. Thank you for attending this session. My talk today is titled The Art of Advanced Ultrasound Guided Intervention for Shoulder Pain. I'd like to share with you some less conventional but effective injection techniques for shoulder pain. Let me begin with a short self-introduction. I'm an orthopedic surgeon specializing in shoulder and elbow, and I work extensively with baseball players. I'm also involved in several team medical doctor and volunteer activities for sports injury prevention. Now, it's my title. What does the art in my title mean? Dr. Onari asked me to talk about the art of ultrasound-guided intervention. To me, that art consists of three key elements: accuracy in injection, real-time feedback, and trust with the patient. This forms the core philosophy of my daily practice. Ultrasound is very useful in evaluating shoulder pain. For example, we can detect LHB inflammation, rotator cuff tears, little ligament shoulder, calcific tendinitis, and then many more. But what do you do when there are no abnormal findings on imaging? A well-known shoulder expert in Japan once said, most cases are not structural abnormal, but rather have functional problems. This means we need to focus more on functional problems. For example, repeated stress to the posterior shoulder muscles cause tightness. That tightness shifts the humeral head forward, leading to impingement and eventually dysfunction of the glenohumeral joint congruity. In these cases, I start treatment by addressing muscle condition. Let's take a look using ultrasound. In throwing athletes, the infraspinatus does not stretch well, and the humeral head moves abnormally downward. This indicates muscle spasm, a state where muscle tension increases due to abnormal nerve activity. To treat this, I perform hydrodissection around the supplying nerve. Even when imaging is normal, athletes often have micro-level nerve compression or adhesion. These techniques can improve both pain and function immediately. This video, left side is before injection and right side is after injection. I often treat overhead athletes, and there are actually many different targets for treatment. But we don't just inject randomly. We should aim with purpose. We strategically choose targets based on accuracy detailed physical exam. Here is my routine physical exam process. It helps me narrow down targets efficiently. Let me show you a case example with a full physical examination sequence. The patient is a 17-year-old baseball player who complained of left shoulder pain during throwing. Specifically, he had anterior shoulder pain at the position of MER. His calf muscle strength was normal, but he showed weakness during the lift-off test. He also had limited third position internal rotation, indicating posterior tightness. The uppercut test was positive with pain in the anterior shoulder, and the scapular assistant test was mildly positive. Other special tests such as CAT and HFT were also positive. Based on these findings, we started with a hydrolysis of the axillary nerve. After the injection, the pain during active MER was partially improved, but not completely. Next, we suspected inflammation around the LHB, so we injected dexamethasone into the LHB area. This improved the entire pain. However, the patient still reported some residual pain on the lateral side. We then performed a hydrolysis of the superlateral brachial cutaneous nerve, which is the brachial branch of the axillary nerve. This final step resulted in immediate symptom improvement, even at the examination room levels. This patient showed positive finding on the lift-off test, third position internal rotation, CAT, and HFT. Based on these findings, I performed a hydrolysis of the axillary nerve. After the injection, active MER showed partial improvement. Next, the uppercut test was positive, so I injected the LHB. This successfully resolved the anterior pain, but lateral pain still remained. In cases like this, lateral shoulder pain is often caused by the superlateral brachial cutaneous nerve. So I performed hydrolysis of that nerve as well. As a result, all symptoms improved completely. If your clinic has an indoor pitching space, you can assess the patient's condition in a setting that is much closer to actual performance. This is a case of a 21-year-old pitcher who came to our clinic to relieve pain during throwing. We evaluated the effect of each injection one by one, immediately after the shot, while he threw. I checked his pitching condition, and injected first suprascapular nerve hydrolysis, and checked a little improvement. Next, I inject axillary nerve hydrolysis and pitching. He can be thrown easily, completely. I normally explain every step of the examination and how to interpret the findings, but due to time constraints, so I will introduce to the injection sites to be mastered and their corresponding examination findings. Today, I will introduce 4 key injection steps that I frequently use and consider especially important. The first step focuses on the axillary nerve and suprascapular nerve. Axillary nerve entrapment is known as quadrilateral space syndrome. It's common in baseball and volleyball players and often confused with frozen shoulder and rotator cuff injury. Let's take a look at what happens to the axillary nerve when the arm is elevated. The nerve is stretched. Next, when the shoulder is pressed in external rotation at the second position, you can see that the stiff latissimus dorsi tendon gradually narrows the entrance to the quadrilateral space. Surgical resection of this tendon has led to symptom relief. Another important paper shows that axillary nerve branches innervate not only the deltoid and teres minor, but also extend widely to the LHB. The axillary nerve also sends branches to the inferior and posterior joint capsula, which means it may contribute to capsule-related shoulder pain. So, when do we consider this nerve as a treatment target? There are many clinical findings that suggest involvement of the axillary nerve. I've listed the ones that I believe are most relevant in order of importance. Please take a look at this video to see the needle direction and spread of the solution. This injection is frequently used and highly effective. I believe many of you are already using it, but if not, I strongly encourage you to learn and try it in your practice. Next, I'd like to talk about injection for the suprascapular nerve. Suprascapular nerve entrapment is closely related to shoulder pain. Suprascapular nerve dysfunction often shows up in the result of calf muscle tests. Many patients have both axillary and suprascapular nerve issues, so I often inject both nerves in the same sideline position. Here is the ganglion cyst. Now, injection and aspiration are usually the first choice, but if the ganglion recurs, surgery may be necessary. This is surgical aspiration of the ganglion. Because the ganglion is hard to observe clearly using only arthroscopy, we perform the procedure with the help of ultrasound guidance. The next step is targeting the thoracodorsal nerve and the pectoral nerve. These interventions help to improve scapular mobility. The thoracodorsal nerve comes from the posterior cord. It runs along the surface of the serratus anterior or latissimus dorsi, and then goes into the latissimus dorsi muscle. The most important physical test in the context is the scapular assistance test, SAT. Do you know SAT? This is the full sequence of the SAT. Please take a look. First, I check for pain during active range of motion to confirm the symptoms. Next, we perform the scapular assistance test and observe how the pain changes. Scapular assist. And do you know seiza? It's a traditional Japanese sitting posture. I ask the patient to perform active range of motion while in the seiza position. This posture makes the pelvis stand upright and helps the latissimus dorsi relax. If the pain changes here, it means the latissimus dorsi is likely the problem. So here is the injection procedure, the thoracodorsal nerve. Next, let's move on to the pectoral nerve. The MPM is the one that penetrates the pectoralis minor muscle. To locate the pectoral nerve, first find the pectoralis minor. It attaches to the coracoid process. The nerve comes from behind and goes through this muscle. I usually perform the injection when SAT, pectoralis minor tenderness, or the heart tests are positive. The injection spreads not only over the surface, but also into the deep portion of the pectoralis minor. The next step is to talk about thoracic outlet syndrome, TOS. TOS is a very complex condition because it involves compression at the root level of the nerve, which can lead to a wide variety of symptoms. Careful history taking is essential. We need to ask in detail whether the patient is experiencing any difficulty in daily life. For physical examination, useful tests include tenderness over the skull area, and Mole test, and Ruth test, and Wright test. Now, here is showing an injection between the skull muscle targeting the nerves. Please ignore this text. It's just the solution I usually use for the block. I target C0, C5, and C6, and C7. Finally, in this last step, we return to a basic technique, intraarticular injection. Most patients get better with earlier injections, but sometimes the pain comes back soon. In such case, there may be mild inflammation inside the glenohumeral joint. And this is when intra-articular injection becomes important. There have been many reports showing that intra-articular inflammation can trigger muscle spasm in the surrounding tissues. So here is the same chart I showed at the beginning. Sometimes the real reason for the pain is joint inflammation, but it doesn't always show up on scans or exams, so it's easy to miss. When performing the injection, I go posteriorly into the glenohumeral joint. Be sure to avoid damaging the labrum during the procedure. So in summary, when you apply the right strategy and perform the right injection, you can expect to see immediately results, and it's important to give the patient
in all over the world. He is absolute pioneer for MSK ultrasound treatment for a patient who has refractory pain. So he is now in the Yokohama City University, and he is doing the outpatient clinic for a patient who has very severe pain for a long time. So in his clinic, there are lots of patients who are coming from the Hokkaido or Kyushu or Osaka to his clinic. His clinic is close to the Tokyo, but there are lots of patients who are coming from other far area. And he's also a president of our Congress of the Japanese Orthopedic Ultrasonic Society in the Annual Congress 2027. So please come to Yokohama 2 years later. Okay, anyway, so today I asked him to have a lecture about silent manipulation for frozen shoulder. So don't miss it. Are you ready?
Okay, thank you. Thank you, Dr. Omodani, introduced me. Today, I'm very happy to see so many people again. After such a long time, friends from Taiwan, Korea, and Philippines, and Thailand, and many other countries I met before COVID-19. So I will talk about indications, procedure, and post-operative management of awake manipulation for frozen shoulder. I'm Kazuma Miyatake from Yokohama City University, and my expert is shoulder and elbow. So first, how many doctors do awake manipulation for frozen shoulder? Oh, 1, 5, 6, 7. Oh, many. Okay. Today I talk about indication, procedure, and post-operative management.
And COI disclosure is shown here. So first, what do you do if a patient with shoulder pain come to your clinic? In Japan, almost all orthopedic surgeons take X-ray at first in Japan. But there are only a limited number that can be diagnosed by X-ray, such as osteoarthritis of the shoulder, calcific tendinitis. But one paper reported that a study of 32 patients with shoulder pain, joint pain, all 32 patients have normal X-ray. So, X-ray can, as you know, X-ray can diagnose 10% of shoulder pain. So, because X-ray cannot detect many shoulder disorder, so older orthopedic surgeons tend to diagnose all shoulder pain as periarthritis.
Same everywhere.
Same. However, as you know, ultrasound can be used to diagnose almost all conditions of shoulder pain. For example, rotator cuff injury, biceps tendinitis, and subacromial bursitis, and frozen shoulder, and so on. Ultrasonography can diagnose 90% of shoulder pain. So, ultrasonography is more useful than X-ray for diagnosing shoulder pain. But ultrasonography is very useful. There is something more important thing. I think many of you like using ultrasound, but I want to say again that physical examination is very, very, very important. So this was referred to our hospital with suspected rotator cuff tear.
So, 両方、右、
right shoulder.
OK です。横から、横から上げて、これこんな感じですね。で、肘。
This patient was referred to us with a suspected rotator cuff tear.
今度横から上げていきましょう。こうですね。そうですよね。で、脇締める。
And this was referred to us with a suspected rotator cuff tear.
ここはもう辛いかな。
全然逆を。反対の手。そう、そっち平気ですね。
So all three of these patients were referred with suspected rotator cuff tears. However, only one of them actually had a rotator cuff tear. So it can be easily identified using a simple three-step approach. I'd like you to remember this method and take it home with you today. So first step, we check biceps muscle strength. So first case, watch again.
横から、横から上げて、これこんな感じですね。で、肘。
In this case, the diagnosis is cervical spondylitic atrophy. So, in the case of CSA, muscle weakness of biceps and the spinator muscle always appears. So, after physical examination, we should take MRI. The patient can flex the elbow with some effort.
ゆっくりやれば曲がる。頑張って。なんとかいくけど、力抵抗かけます。
But cannot resist against applied force.
これは抵抗には勝てないですね。OK です。今度は、こっち回します。そうそう、力がします。
While pronation strength is preserved.
これ力入りますけど、今度はこっち側を回して。
Spination strength is weak.
これが入らないですね。自分で回せます。一応回せるけど、グッと入れますよ。
So about 3 cases a year,
mixed in with the shoulder outpatient clinic. So in these cases, we recommend that you refer to spine surgeon. So if the patient with shoulder immobility, first step, you check muscle strength of biceps and spinator. If they have muscle weakness, you can diagnose CSA, like Keegan type. And if they do not have muscle weakness, next step. Next step, we check range of motion. Which range of motion are you focusing on? Flexion, abduction, external rotation, or internal rotation? We especially need to tell the difference between a rotator cuff tear and a frozen shoulder. Frozen shoulder is often diagnosed wrong, so I will explain what we should check. Let's review the pathology of frozen shoulder. One of the main features of frozen shoulder is contracture of joint capsule. In particular, thickening of axial pouch often occurs. This can be confirmed using MRI, especially when saline is injected into the joint. You can clearly see the axial pouch have little space and is thickened, like this. You can also detect this with ultrasound. Real-time observation is helpful. In a normal shoulder, saline spread into the pouch, so the joint capsule does not visibly expand after injection. But in frozen shoulder, the pouch is shortened, so the capsule clearly appears swollen after injection. Like this, in a normal shoulder, the saline spread into the pouch, so the joint capsule does not appear to expand after injection. But in frozen shoulder, the pouch is shortened, so the capsule quickly looked swollen after injection, like this. So, thickening of the pouch causes limited flexion and abduction. But from these physical findings alone, we cannot diagnose if it's a rotator cuff tear or a frozen shoulder. So, the next things we should check is thickening and shortening of rotator interval. The rotator interval is a space between subscapularis and supraspinatus, where there is no rotator cuff tendon. If rotator interval gets stiff, it will not be able to open, such as retraction of external rotation. So the article reveals that true frozen shoulder has external rotation restriction. So second step, we should check external rotation. There is no weakness in the biceps and the pronator muscle, spinator muscle. And the flexion and abduction are limited.
そうですよね。で、
There is external rotation restriction.
後ろ手回しましょう。どこまで手下がりますか
And there is internal rotation restriction too.
OK です。
Next, which do you focus on, active ROM or passive ROM? In rotator cuff tear, passive external rotation is usually not limited. Passive ROM is more important. And the most important point, adduct the shoulder and ensuring that the elbow does not move away from the torso. In this case, rotator cuff tear, there was no muscle weakness of biceps and spinator muscle. Passive and active external rotation is normal
反
range.
対乗ってそうそっち平気ですね脇締めます開きますそれは開く
So
んで
this
す
is
ね
not frozen shoulder. This is rotator cuff tear. So if there is a passive external rotation restriction, diagnosis is frozen shoulder. If there is no passive external rotation restriction, next step. Next step is special test of rotator cuff. First, Furcan test is the most famous. In the supraspinatus muscle tear, the sensitivity of Furcan test is 83%. Empty can test, next empty can test. In the rotator cuff tear like SSP and ISP, the sensitivity and the specificity of empty can test is around 70%. And belly press test. Belly press test is a test for subscapularis tear. Sensitivity is 88 point and specificity is 68%. And last, bear hug test. Bear hug test is test of subscapularis muscle tear too. Sensitivity is 88%. So the diagnosis is made by combining 4 different tests. This is a case of rotator cuff tear.
逆は
Restriction of flexion and abduction.
手を戻して横から上げます力こぶつけましょう
Muscle weakness of biceps and
これはありますね
spinator is no.
そうです向き逆グッ OK ですね力入りますね
Not
自
CS.
分で開いてこれ開かないですね自分で開いて
Active external rotation is restriction, but passive is no
この
restriction.
状態で上にグッと上げて
Full can test and empty can test as positive. Very press test negative. So this case is massive rotator cuff tear, SSP and ISP. So we check a special test and we will perform an ultrasound examination at the same time. The ultrasound finding also rotator cuff tear or something like calcification and so on. This case a rotator cuff tear. Today I will talk about management and treatment of frozen shoulder. So I will talk about silent manipulation. This is awake manipulation of frozen shoulder procedure, but I think not silent. You can hear a loud sound when the capsule release. So for frozen shoulder, conservative therapy is a good option. Conservative therapy is usually successful, and most cases go into remission after 2 or 3 years. But even after 7 years from the onset of the disease, more than 50% of patients remain in pain and limited range of motion. So treatment are many options, but I like silent manipulation. Silent manipulation is awake manipulation procedure under cervical nerve block. This paper was written on the recommendation of Dr. Kentaro Onishi. And the method, in the actual method, C5 and C6 level are drawn and the solution is inserted between C5 and C6 ultrasound guidance, under ultrasound guidance. In order to expand the solution, local anesthesia is spread above C5 and C6. And recently, we have also performing C7 block. Why do I do C7 block? Do you know osteotome, sclerotome? We also block C7 because the bone where the tightness part of the joint capsule is attached is controlled by C7 nerve, like this yellow area. So I do C7 block too. And we inject triamcinolone to intra-articular by ultrasound guidance before or after silent manipulation. Now I will show you how do I silent manipulation. First, do external rotation until you feel the capsule release. Then move quickly into adduction to release the anterosuperior capsule. And after that, I use flexion to release the bottom part. Abduction with internal rotation help cut any parts that are still tight. And adduction with internal rotation to sit on chair with hoil and do extension with external rotation, extension with internal rotation, and repeat this procedure 2 or 3 times to make sure nothing is left. At the end, try the hand behind back position. If it's still tight, release the capsule more until the motion is smooth. I introduce the patient with bilateral frozen shoulder, like this.
OK です。戻します。脇締めて開きます。脇ちゃんと締めた状態でどこまで開きます？右これぐらい、左これぐらい。OK です。
Rehabilitation for more than half a year. Injections are also ineffective with night pain. So, right, I did silent manipulation. After 1 week, the range of motion was very good, like this.
まっすぐ上げてください。横から行きます。
Without night pain, and hand behind back was also good.
で、脇締めて開いて。ウィッと。逆は
So, Dr. Park in Japan reported that effect of silent manipulation. He is a monster who performed 1,400 cases of silent manipulation in just 4 years. In his report, he presents data from 800 cases, where 3 months follow-up was available. Although the follow-up period was short, only 3 months, there was significant improvement in flexion, abduction, and external rotation. Silent manipulation is easier and cheaper than arthroscopic surgery, and the good results same as arthroscopic surgery. So, last year I reported result of silent manipulation after 1 year. Checkpoints are flexion, abduction, external rotation, hand behind back, and dash score and shoulder 36 score. And silent manipulation was performed by the same method, one with more than 5 years experience and the other with less than 8 years experience. And we checked 43 patients. All patients undergo MRI before manipulation. Just after manipulation at 3 months and at 1 year. Saline is injected into the joint before manipulation and at 3 months and 1 year. Just after surgery, we can confirm that the rotator interval and the axial approach have being released, like this area. And improvement of joint capsule thickening and spreading actually pouch like this 1 year, after 1 year. So flexion and abduction shows significantly improvement immediately after procedure, with further improvement observed over the following year. External rotation and HBB are good result after procedure, and patient-reported outcome measure are also good after manipulation. In this study, no complication. There are a few important points I'd like to share. Thyroid dysfunction and diabetes are elevated factor in this primary frozen shoulder, suggesting that it affects not only the trigger but also the prognosis. So in addition, it was thought that extra-articular contracture was also complicated. So diabetes and thyroid dysfunction have slightly poor result after procedure. And the next, result change with experience. So flexion and abduction show little difference, but the hand behind back and the external rotation do vary with experience. Like this, and pain, daily activity, muscle strength do vary with experience. And the last warning point, this is not the perfect treatment. 1 out of 30 patient is not satisfied and may end up needing arthroscopic surgery. So this is a patient who underwent an arthroscopy capsule release at our hospital because silent manipulation was performed at another hospital and the results were poor. In this case, the post-operative range of motion is quite limited except for flexion. 160 flexion, 100 abduction, and 20 external rotation. However, after 3 months of ACR, the range of motion had improved. In the arthroscopic findings, the joint capsule looks red and the synovial membrane is swollen. Compared to healthy people, there are many adhesions. The thick joint capsule is carefully separated to avoid hurting the muscle. At the end, you can see lower part of the joint capsule has been cut. So from the above, the flow of treatment at our hospital is, first of all, for about 3 months of rehabilitation for patients with frozen shoulder. However, patients referred to our clinic do not improve after about 3 months of rehabilitation, so we will perform silent manipulation at an early stage. For patients with type 1 diabetes for those with poor outcome after silent manipulation at another hospital, even after repeating silent manipulation at our clinic, we perform arthroscopic surgery. So let's try silent manipulation together. Thank you. And next, flexion and abduction and passive external rotation. So point is adduct shoulder because
to prevent the compensation.
Yes. 代償っていうことなんです。
Compensation.
Compensation. So adapt the external rotation. And next, full cam test, empty cam test, belly breath test, and bear hug test. And if I suggest LHB disorder, speed test, and Slap O'Brien, and so on. And same time, we check ultrasound. Rock, and if the pain is slightly remain, like
chest pain.
chest area, I add
Right, okay.
PEX block.
PEX block.
block.
Under
Yes.
the PEC measure.
Yes. And if remain
Scapular area.
dorsal.
Latissimus dorsi.
Yes. So I add 胸背神経.
Thoracodorsal nerve
Yes.
block.
Okay. And first, I released superior anterior area for abduction 45 degrees and external rotation, and sound pili.
So you hear the pop of the sound of the capsule breakage.
And quickly adduction. And boom. And the next external rotation, adduction 90 degrees level, like this, and flexion and internal rotation, abduction. And next,
horizontal flexion.
Horizontal flexion and internal rotation. All area, like this.
Combination.
Yes. And next, I sit chair. But most important thing is using wheel with wheel chair.
So if you use the chair with wheel, you can move smoothly. So you cut the capsule with the movement of the chair.
Yes.
I see.
And first, extend portion like this, and above knee, elbow is there.
You put the patient's elbow on your knee.
And
the chair moving.
And extended block,
external rotation.
Extended block and external rotation. Like this, and external block and internal rotation, like this.
The combined motion.
Yes. It's very important. Extended block is very important. And this procedure 2 or 3 times.
Not just one time, but 2 or 3 times.
Yes. And last, hand behind back position. If scapula elevated.
So we should stabilize the scapula.
Yes. So if behind back position, scapula elevated, we broke in the last like this.
Yeah. So we should prevent the compensation of the scapular motion.
Yes. Like this and boom. Boom. Yeah, it's finished.
Okay. Thank you for your live demo.